Hey
Hey
guys.
guys, hope all is well.
Oh, Benjamin, that's a cool background. Ooh, psychedelic. I like it.
Now he hears you. He didn't know.
I complimented your background, Benjamin. I like it. It's psychedelic.
Just turn it off when I'm talking. I can't focus, please. Just kidding.
It's like,
All
okay.
right. Well, cool. So we'll cover renal today. The slides were posted on Scrubs. It'll be a long one, but we'll get through it. Lindsey, I'm sure everybody saw your post. Do you want to update them? How you feeling?
Yeah. Yeah. I'm doing good. Pretty mild everything. It's really annoying more than anything else. It's disappointing because I'm vaccinated and I'm trying to get to the island. But thank you for the outpouring of love. I really do appreciate it. I wasn't going to tell people, but then my symptoms were getting worse and I wasn't coming to the island and I knew I was going to see you guys. And so I thought my med school fam deserved to know what was going on with me because you guys, you love us and you come to our reviews. And so I wanted you guys to know what was going on. But yeah, I'm doing good.
Good. Good to hear. And she's planning on getting down here soon. Negative test, and then she's gonna head down.
Yeah.
Good stuff. All right. We'll do our usual thing. The the playlist is on Scrubs. The videos are private, so you need to use the playlist. Just bookmark it, and you can get to your playlist. You can see all the videos we've done. Also, this is not affiliated with school, but you should follow IEA. For those of you that are fortunate to get honors, you'll be able to apply in August. We're going to do some fundraisers, offer tutoring, stuff like that. So follow us on Instagram, and yeah, we'll go from there. All right, so you have gotten to know Lindsey and I pretty well over the term, so I'm going to share a little story with you guys. Renal is very near and dear to my heart. So when I was 20, I found out I was diagnosed with a genetic kidney problem that I had from birth. My father never knew, so it was news to me. And from that point on, I had a significant decline in kidney function until eventually my GFR was under 10%, and I was strapped up to a dialysis machine every day, and I just wasn't doing very well. And the idea of going to med school was just a dream. So yeah, my aunt actually got tested. I didn't even know, and she ended up being a match. And so 2.5 years ago, I got a kidney transplant, and that is why I'm with you guys today. Um, Without that, I don't know where I'd be if I'd be here at all. But I'm very blessed that happened. But I'm telling you guys this for a reason, because I remember when I was finishing term one where you guys are now, and I think it's easy to lose the forest for the trees, right? So what does that mean? It's easy. You're hyper focused on these small details that it's very difficult. You lose sight of the big picture, which is that this is a rite of passage, right? To do one of it, I think uh, unequivocally the greatest job you can have, and that's for people to come to you and genuinely need you, and to be able to help people and to be able to heal people physically and emotionally. And I could tell you, I'm sure many of you have had similar stories, but seeing the hospital bed from the other side as a patient, I had all the support in the world, but it was an extremely lonely experience. But what gets you through are those doctors that are committed, the nurses, the staff, everyone, family included. But what I found through this process is that the best doctors out there are the ones that suffer with their patients. And sometimes that hurts. Like, you go into it knowing that, but those doctors are the ones that make a real difference. Not only do they suffer, but they also persevere with their patients, right? So it's such a rewarding experience. And, all those great doctors have been through what you're going through now. So as you close out, and this is our last review with you guys for the term, just don't lose sight of the big picture, the big goal, because that's what dictates everything. These little things are just come in passing, right, as time goes. But the overall goal is to get to a point where you can change people's lives. Okay. Now, that being said, we'll go ahead and get started. So I'm on Scrubs, Lindsey's on Dog Mom. As always, we post our stuff for you guys. Y'all can check it out. And right, so we'll start with the anatomy, some basic stuff. You can see the kidneys like retroperitoneal right behind that peritoneum. So they're kind of pressed up against your back. One of the things they like to test on is the difference here is that the left renal vein comes down directly, the left testicular vein comes directly off the left renal vein, okay? And then the right testicular comes off the inferior vena cava. We did have a question like that. It's pretty common. Guys, that's why your left testicle hangs a little bit lower than your right. Don't check right now, but take my word for it. And then another thing they like to test on is this ureter. This ureter crosses over here. If you've ever heard the water under the bridge analogy. So when they do hysterectomies, we'll look at it a little bit more in a bit. When they clip those ovarian uterine arteries, they need to make sure that they don't accidentally cut the ureter. So that's just a little bit. Due to the liver, where the liver is, the right kidney is a little bit lower, but they usually end around T11, T12, okay? You can see that more here. You could appreciate that that left kidney is it's tucked up under behind the spleen on the left side. And yeah, right. So if we look at the inside, the drainage points, so the cortex will have like your glomeruli, right? And then they drain through to the medulla, and then everything ends up in these calyces, which drain into the hilum, into the ureter, down to the bladder. And we're going to dive into these a lot more detail later. And then when we talk about the functions, right? Some of the things that may not be intuitive is that if your body feels like it's hypoxic, it can secrete EPO or erythropoietin, and that's going to stimulate the bone marrow to make more red blood cells. So the more red blood cells you have, like we talked about in pulmonary, the more oxygen carrying capacity you have. Also, we're going to talk about at length the RAS system, renin, angiotensin, aldosterone system. And so that's going to help to regulate your blood pressure and your blood volume. And then, of course, you know by now, vitamin D, 25 hydroxylated vitamin D comes from the liver. You use one hydroxylase in the kidney to convert it to 125, which is your active calcitriol or active vitamin D, which is super important. Remember that question that always comes up if a patient comes in with chronic renal failure. Why are their calcium levels low? And that's because they can't fully activate vitamin D to the active form. And then homeostasis, of course, these are mostly water and electrolyte balance, getting rid of things like especially urea. People with chronic kidney disease end up having a lot of urea, which would cause a multitude of symptoms. And then acid-base problems, which unfortunately they waited to the end to teach you guys. Somebody let me know, do y'all have lecture? No, we don't have class Monday. Okay, so y'all have done acid-base stuff. Right, y'all must have, if y'all don't have lectures. Right, so unfortunately they waited to teach that stuff till the end, but it is by far the most important. We probably had 15 or 20 acid-base questions. So when we get to the end, we'll take a break and then we'll go through that and we'll go slow. We'll make sure you guys know how to do those. It is just, I have a systematic way of doing it. You could do them all the same way like that. And so if you follow the steps, it's the same way Dr. Mpadya does it. So I like that way. It's very systematic. So we'll go through those at the end. All right. It's probably good to know these. I know I hate memorizing things, but this kind of gives you just, goes from large to small. They could ask you these sort of things. Remember, afferents come in, efferents go out. Okay, embryology, same principle we've done for embryology this whole time is that they like to test on abnormalities. So they're not going to ask you all these different definitions about development. Primarily, they're going to say, you had this sort of kidney issue in development. What was the problem? Okay, so it's the same as it's always been. But just some basic definitions here. You can see that the mesoderm and urogenital sinus, they kind of come together. And I think I have better slides for that. Right, so yeah, I do coming up. So the metanephros will be your permanent kidney. So it kind of forms through this process. Eventually you get to the metanephros, and that's gonna be your permanent kidney that binds to that uteric bud that's gonna form the urinary system. And here we go, this uteric bud is an outgrowth from the mesonephric duct, and it's gonna have that drainage pathway for it down to the bladder. So permanent kidney, and you can kind of see that here. You see this uteric bud. It has to, it has to bud out. This is a good picture actually. So that's how it forms the uteric bud. Everything in pink here is going to be your urinary system, and this brownish area is going to be that metanephros, or it eventually forms the metanephros. So that's the idea here. And as it grows, you see these pink, those are the calyces. So everything from that point down, the kidney's basically just draining everything from the collecting ducts down to the kidney. I'm sorry, down to the ureter, to the bladder, right? So don't get bogged down with this. The only reason I put this on here is because there's some problems that can develop with this ascent and rotation. I must have another slide with the horseshoe kidney coming up. Yeah. Okay, and then again, same thing. Remember those adrenal glands kind of sit on top. Those are kind of monitor your epinephrine, norepinephrine, your catecholamines basically, and it sits right above the kidneys. Let's see, renal agenesis. These are the, let's see. Yeah, so if you don't have that formation of the ureteric bud, it has to bind to this metanephros here. If it can't, then you don't have a connection that can actually form to drain the kidneys. It's kind of just floating if it develops at all. What also is important, make sure you know these are the problems that can develop from not having that. So remember, oligo means less amniotic fluid. So if you don't have kidneys, remember the fetus in the womb is going to swallow the amniotic fluid. It'll help to develop the lungs, but also the fetus has to urinate it out, or back into the circulation, or get it back out through the circulation. So if it can't do that, then a lot of the amniotic fluid is going to be stuck in the child, right? Because you can't get rid of it. And that's why the overall you would have oligohydramnios, because there would be a lot in the child, you can't get rid of it. Of course, secondary to that, if you end up with oligohydramnios, you're not cycling through all that amniotic fluid. So you get pulmonary hyperplasia, you can't develop that. Platter sequence just is this sequence. You don't need to get too bogged down with it, but it includes renal agenesis. And of course, you need, if it's bilateral, you do need some sort of renal function, at least one, to survive. And then this is just a little bit more. So you could have this double kidney. This is actually common in the population. Usually you don't know it unless you go get some sort of retrograde urethrogram, but you do just to see these multiple uteric buds. So they could either come off of the same stalk, or right here, or they can develop separately. But you can see if it's two uteric buds, that means you're going to get two ureters, right? Versus this double kidney, this bifid ureter. These are buzzwords you need to know. This bifid ureter is going to come together, and then one drainage point to the kidney. Doesn't seem very important, but it's just some of the semantics, because this does happen in the population. Put a star on this one, horseshoe kidney. What you need to know is it gets caught under the inferior mesenteric artery, okay? Because technically, when you think about it, just in normal people, y'all have heard of the nutcracker syndrome. So that renal vein actually sits under the superior mesenteric artery. And if there's some sort of acute angle there, it can cut off blood flow to from the renal vein, or renal artery and renal vein, to and from the kidney. Now, that's not what we're talking about here. What we're talking about here is the kidneys have to ascend from the pelvis all the way up. So the first point that it gets caught at is that inferior mesenteric artery. And you can kind of see that here, right? This inferior mesenteric artery is here. You can see the horseshoe kidney, the little ureters coming through here. So definitely a test question, easy points. All right, they also like this. You can see the kidney here, and I put little numbers here. So inside to out, you have this fibrous capsule. The perirenal fat is right around the kidney. The then you have this renal fascia that goes in between the peri and pararenal, and then pararenal fat is on the outside. Okay. It's important, the question they may ask if somebody has some sort of injury, some sort of knife wound to the back, what's the first layer of the kidney you go through? So you can see that here. Now, when they do kidney transplants, the one the way they did it for me, they actually put the extra kidney or the transplanted kidney in your abdomen. Now you can appreciate why, because there's so much muscle and so much issue getting to the normal kidneys that you don't really want to go through the back if you don't have to. They actually left my old kidneys in, and they won't take them out unless they cause me a lot of pain or problems. And there's a couple of reasons. One, it's just a very serious surgery to have to go through and take them out through the back. You don't want to compromise these back muscles, but also if for some reason the transplanted kidney has some sort of rejection, there is a small bit of residual function in the original kidneys. This is pretty much classically people with end-stage renal failure, long-standing diabetes. If they need a transplant, they tend to leave the older kidneys in. And there's a picture of the actual surgery that I'll show y'all a cartoon image of how they actually do it. Now, super important, this could be called hepatorenal recess or Morrison's pouch, okay? So these areas are very important. You'll talk about this one in the pouch of Douglas. So if the patient is laying down, okay, patient is supine, this is the most dependent place, most for gravity to go downward. That's so if there's some sort of abdominal trauma and you're looking for fluid, that's where you're going to look. You could use an ultrasound guided probe and you could try to see if there's any sort of fluid development there. So that's very important, hepatorenal or Morrison's pouch. They'll ask you, patient supine, where's the fluid going to go? Okay. And then pain from the kidneys. Remember, we're talking about kidneys, so visceral pain, so very dull type pain. And you can see this derivation here of how everything goes. Okay. Oh, okay. Now, this is that water under the bridge. So typically they can do this when guys get a vasectomy, but the main thing they talk about is in females when you get a hysterectomy, okay? So you take out the uterus, you have these uterine arteries and uterine veins. So the water is the urine in the ureter, okay? So the ureter goes underneath. To take out the uterus, you have to cut the uterine artery and uterine vein. Just make sure you don't go too far to the water part, which is the ureter, okay? So there's some crossing points. I have another slide coming up and it will show y'all the crossing points. This is like if a guy has a vasectomy, you can compromise this, but the question they always ask is the hysterectomy. Now, this is important too. Why is this important? Because kidney stones are very important. Very painful, and this is kind of the points where they get these constriction points. So the uteropelvic junction is kind of a small point here, kind of where the lower pole of the kidney kind of butts out, and you can get a constriction there. Another one is where the ureter crosses over the iliac arteries, and then you also have the point where it actually enters the bladder, this uretovesicular junction, okay? So you could get a stone lodged in any of these places. Depends if you're the patient or the doctor. Ideally, as a doctor, you want the patient to be able to pass them if they're small enough, even though it's very painful. Sometimes they have to do what's called a lithotripsy, and they use shock waves to kind of break them up. But again, you don't want to do surgery if you don't have to. So what you need to know now are these constriction points, okay? Right, and so let's look at this here. So see our kidney here. You see the calyces, this drainage point. This question mark would be the uretopelvic junction, right? But look, it's hard to appreciate without seeing a normal ureter, but this is very dilated, okay? And the point is right here, you can see the stone. So where's the stone lodged? The uretovesicular junction, right before it gets into the bladder. So it doesn't have to go too far to get to the bladder, which is kind of a good thing versus being up here. But you could see this. But if you compare this, you could even see some of the calyces are dilated too. So this actually, what you'll learn in term 4, leads to hydronephrosis, hydro meaning fluid in the kidney. So you get a backlog of all this fluid here, okay? And that could cause kidney problems, lead to some sort of infection. So you need to deal with these stones. Very common in Western civilization with our diets and stuff. All right. whoops, here we go. Just some basic definitions here. You can get cyst formation versus a sinus. A cyst does not drain. A sinus can drain, but it does have a closure point. And a fistula is a very important word that comes up again and again, is an aberrant connection. So you get urine drainage. It's hard, if you ask me why there's a drainage here, if it's closed off, I'm not exactly sure. I think it's just some sort of fluid that can actually drain into the sinus, but it's not necessarily from the bladder. What you see in the fistula is actually urine coming out of the umbilicus. You can see that in children. Okay, see it here, the little cyst. So just make sure you can differentiate a cyst from a sinus from a fistula. All right, clinical anatomy. I mentioned this before. Now, very important, this pouch of Douglas, also called the rectouterine pouch. Since it's got the word uterine in it, this is only in females, right? The guys have a rectovesicular pouch, but they talk about this pouch of Douglas because if the patient is standing and there's some sort of trauma or fluid that develops in the abdomen, this is where the fluid's going to go, okay? So if you're worried about trauma and some sort of internal bleeding, that's what you're worried about. The words you need to remember for that is a coldocentesis. They can actually go through the rectum and they go through the vagina and they go and they puncture through here and they can drain the fluid. That's called a coldocentesis. Yeah. Then if we look at some of the innervation, just make sure you have this straight in your head. Once you get it, it really makes sense. So visceral afferents, organ sensation, right? So that's those stretch fibers. When you have a full bladder, you can kind of tells you need to go to the bathroom. Okay, so parasympathetics are going to be on the muscle level, this detrusor muscle. So parasympathetics, you can pee, right? That's what you're supposed to do with parasympathetics. So parasympathetics will cause this muscle to contract. Now, the sympathetic system has to be turned off, right? So you want to activate parasympathetics to pee and turn off the sympathetics. So what you see is these sympathetics, the sphincter, right? So this smooth muscle sphincter that's around the base of the bladder, well, if the sympathetics are activated, it'll be constricted, so you can't pee. And then the parasympathetics will help to relax that. So let's say, take for example, parasympathetics, okay, you feel these visceral afferent, these stretch fibers, you have to go to the bathroom. Parasympathetics activated, so we're gonna constrict the muscle that's around the bladder, but also we're gonna inactivate the sympathetics, so we're gonna relax the sphincter. So you can squeeze the bladder, relax the sphincter, all is well. The opposite is true if you don't wanna pee, sympathetic, so parasympathetics are turned off, you're not going to contract the muscle. Sympathetics are activated, so that sphincter is tight, okay? So they just work in opposition. Let's see, one of the important things here is that UTIs are more common in females, primarily because they have a short urethra, right? So less distance for the bacteria or whatever to get into the bladder. And then of course, the proximity from the vagina to the anus and intercourse. But the main thing that they talk about is this short urethra. And then the male urethra, y'all will get into this more next term when y'all do reproductive. They talk about a bunch of these different saddle injuries or different break points. But for now, you just need to know the different areas. So prosthetic urethra is around the prostate, goes right through the prostate, which you can see here. Membranous urethra is after, and then you have this penile or spongy urethra that goes through for drainage. So that's all you really need to know for now. I don't think y'all get into the injuries till y'all do reproduction. And then catheterization, of course, you can see if you put a catheter in here, this point here where you take a 90-degree turn, that's going to be the point of constriction that you get a lot of problem. Patient has to take a deep breath, you just go with it. All right, PKD, you can see here, these are very enlarged kidneys. There's an autosomal dominant form, and these cysts form directly from the nephrons, right? So the more cysts and the bigger the cysts get, the less renal function you'll have. You don't usually see that till adulthood. The recessive form is much worse. They're very different, and y'all get into this in pathology later, but the recessive form tends to happen in infancy. But remember, with PKD, the question they like to ask is, it's bilateral. Of course, it has to be bilateral because it's a genetic condition, right? Now, renal transplant, this is exactly how they did it for me. They leave the older kidneys in your back, right? Because there is residual function, hopefully. And they actually transplant it on the right side, kind of adjacent to your appendix. They kind of make a little pocket around your intestines, and they just slip the kidney in there. They connect the renal artery and vein to the iliac artery and vein, okay? And then they make a new ureter. And what's not fun is they put a little stent here, and about 3 months after, they have to go in retrograde and pull the stent out. So that's not fun. I could attest to that. And then stress incontinence. Incontinence means you can't hold your bladder. So any sort of stress you get on the bladder can cause incontinence. And then a cystocele is when the bladder can protrude into the vaginal canal and come out. So that can happen sometimes after pregnancy, stuff like that, but that could come through. It's just a prolapse, right? So it prolapses through the vaginal canal. Okay, so you can surgically correct that. All right, histology. Don't stress this stuff. I'm going to show you all the pictures, and by the time we're done, you'll know what they could ask. All right, it's not as bad as you think. Right, so we're looking at the nephron here. This entire thing is the nephron. We start with the glomerulus, right? There's millions of these in the kidneys, and I think it's, I might get this wrong. 1/5 of the blood that comes through, don't quote me on that, actually goes through the kidneys each time it goes around. But anyway, that's a lot of blood to deal with, you know, at a time. So you take these glomeruli, these millions of them, and they have little holes in it. And we'll look at those in a second. And through these holes, the urine is passed through, and things such as red blood cells are too large to go through. So we're looking at ions and proteins and stuff like that. And then through this process, through the loop of Henle and whatnot, you can pull back what you need, get rid of what you need. It's very fine-tuned process to be able to urinate the things you want to urinate and keep the things you want to keep. So we'll get into it. So you can see what they call this glomerulus is a tuft of cells, a tuft. But basically what it means is, or a tuft of capillaries, excuse me. Basically what it means is these capillaries come through, and the urine is pressed out into this urinary space, or Bowman's capsule. You can see as the blood comes in, it goes through and it's kind of pushed out. It's like filtered through. And then from there, you can get to the proximal convoluted tubule. So you should take a snapshot in your head of what this picture looks like, right? Glomerular capillaries. Of course, this space is going to be where the urine comes through. And you can see a little bit closer, these podocytes are like little foot processes that kind of make the fenestrations so that the fluid can go through here. And these slits are very small, but you could see how the urine can kind of be pushed through there, keeping the larger things like cells in your system and get rid of the smaller things. Very important to know that these are the things that are going to dictate whether the blood could get through, or excuse me, the urine can get through. Charge is a big thing. Negatively charged molecules tend to be repelled. Size also is a big thing. This is why red blood cells are kept and don't go. You shouldn't have any blood in your urine. And then shape matters too. Excuse me. So if they ask you any sort of things like this, they'll probably ask size. That's pretty straightforward. But there are also some other things that dictate what we're looking at. All right, now, in regards to the tubules, this image, this H&E stain, they'll probably ask you either proximal convoluted tubule or distal convoluted tubule, okay? So you need to be able to tell the difference. The way I tell the difference is that the proximal convoluted tubule has about 5 nuclei, okay? It's kind of sparse, okay? Versus what we look at when we see the distal convoluted tubule, there's a lot of nuclei and it's tighter, okay? So the proximal convoluted tubule, one of the major goals of the kidney is we don't want to lose protein, right? You should never have protein in your urine either. You want to keep your protein. So it's going to pull back all the protein. Glucose too. You don't want to lose glucose if you don't have to. So we're going to pull back all the glucose. Now, diabetic patients have so much glucose that it overwhelms the system. So if you get glucosuria, right, glucose in your urine, maybe you're thinking diabetes. Sometimes it happens in kidney failure too. So these are the things. Pretty much urine should be sterile. It should be composed of urea, mostly water, stuff like that. But if you have proteins or glucose in there, you need to investigate a little bit further. All right, so proximal convoluted tubule, again, you could see these nuclei are kind of sparse, right? You can see around here. Right, and also if you're trying to differentiate looking at proximal to distal, you'll see a lot more proximal convoluted tubules than distal convoluted tubules, okay? Now, we'll get to distal in a second, and I'll show you them next to each other so you can differentiate these. But the next thing is this different view, this longitudinal view of the loops. Now, there are three things that I think that they could ask you. The first one is this empty space. So this empty space or this lighter area that we're looking at is going to be your loop of Henle. Now, how this works is the vasa recta is the blood-containing vasculature around the loop of Henle. Okay, so what happens is not blood, but the urine components, whether it be salt or water, can be transferred from this clear space, this loop of Henle, to the vasa recta, to the blood. Okay, so you could kind of see here these little blood vessels going around, but they just lay next to each other. Okay, so it could transfer from the urinary system to the blood, back and forth as they go around the concentration. Now, I'm telling you this for a reason, because they could ask you this clear space, which is the loop of Henle, but remember the vasa recta is blood components, it's vasculature. You see, these are red blood cells. So anytime you see them running next to each other, you see this loop of Henle here, and you see the vasa recta here. Giveaway, if you see red blood cells, it has to be vasculature, so it has to be the vasa recta. Okay, and you could see that here. Right here, you can see the loop of Henle, and you could see right here is the vasa recta, and we'll get to this one in a second. All right, again, vasa recta, right? A little bit different of a view, but you can kind of see the red blood cells that come through here. But the whole point is that they wrap around each other just so they can transfer things back and forth. So same thing here, we're looking at the vasa recta with blood, and the loop of Henle is clear. Look for red blood cells for the vasa recta. Now, distal convoluted tubule, I have some closer up views, but if you look here, you can see there's a lot more nuclei. They're right next to each other. So that's how you're going to differentiate the proximal versus the distal loop of convoluted tubules. You can see there's a lot more there, and they're kind of a little bit, they're a little bit more eosinophilic, but I think I have a better image coming up. But yeah, they're a little bit smaller. Remember, they're less abundant than the proximal convoluted tubules, and they have more nuclei. So yeah, again, I just want to point out that the ratios are different. You're going to see a lot more proximal to distal convoluted tubules. Let's see if we can look at some. So I would say like this proximal, but look at this one next to it. I would say that that's distal, right? So you could appreciate the difference. Proximal is kind of looks a little bit bigger, less nuclei. Distal is going to be smaller, more eosinophilic, so a pinker stain, and more nuclei. Okay, now the macula densa is going to help to monitor how much sodium you have in your system. So remember, sodium and water go together. So if you have a lot of sodium, that could be indicative that there's a lot of water around too. So the macula densa is going to be here. And when we talk about that renin-angiotensin-aldosterone system, that's going to make more sense. But it actually lies next to the glomerulus, all right? So it kind of sits up against it, and that's just a good point to be able to monitor your sodium input. And you could see that here. So when we do physiology, we'll talk about that. I'm just trying to show you the pictures, right? So find your glomerulus, right, our tuft of capillaries, and that macula densa is going to just sit right next to it. All right, so Now we could break this down. This is very important. This is a huge point for medication. Okay, so your volume, the amount of volume you have in your body dictates a lot of things. It dictates your kidney function, dictates how hard your heart has to work. It dictates the vasculature if you have some sort of edema. So you just want to tightly regulate it. And this renin aldosterone angiotensin aldosterone system helps to regulate it. Okay, so what happens is if the body senses that you have too low, hypotensive or decreased blood pressure, it's going to go through two processes. So think about it. If you have low volume, so you're hypovolemic, your pressure is going to be low too, right? Low volume, low pressure. So you want to do two things. You want to save water, and you want to vasoconstrict the vessels. You want to save water to bring up the volume. You want to vasoconstrict the vessels to bring up your blood pressure, okay? So that's what we're going to do. So renin is going to be activated. It's going to go through this process of activating angiotensin. So it's going to go from angiotensinogen to angiotensin 1. For whatever reason, ACE is made in the lungs, just one of those weird things. But ACE is the enzyme that's going to convert angiotensin 1 to angiotensin 2. This is a very important enzyme because they use ACE inhibitors as a first-line treatment for hypertension. All right, so if you inhibit this, you're going to inhibit the process of making angiotensin. Okay, think tense as it squeezes, right? So angiotensin is going to squeeze down on the vessels, bring up your blood pressure. All right, so I hope that makes sense in regards to the blood pressure. Now, think about it. If you give an ACE inhibitor and you can't activate angiotensin 2, you're going to help to decrease the blood pressure, right? Okay, so that's one process. So now we've constricted the vessels, but we also want to conserve volume or conserve fluid. So we're also going to activate aldosterone. Very important. Also used in pharmaceuticals to regulate blood volume and blood pressure. So what aldosterone is going to do is at the terminal end, at the distal convoluted tubule and the collecting duct, it's actually going to use these channels, which we'll get to in a little bit, but it's going to bring back sodium. And remember, anytime we bring sodium back, we're going to bring fluid back or bring water back. So through this process, patient comes in hypotensive, or whatever. The patient is hypotensive, you're hypotensive, whoever's hypotensive. Renin's going to be activated. Angiotensin 2 is going to be activated to squeeze down on the vessels. Aldosterone is going to be activated to bring back sodium, therefore bring back water. Perfect. We brought our blood pressure up. We have more fluid. That's a good day. All right. We'll go through that again just because it's very important. But let's finish off the histology stuff. So the collecting tubule is going to be at the end after you get to the distal convoluted tubule. Okay. And you can see some of, yeah, this is a better picture. So look at this one. So now we're looking at all three in this longitudinal cut. Remember, we said this is that loop of Henle. It's clear. We find our red blood cells. We have our vasa recta. Now they refer to this as like a dirty lumen. But you can kind of see how there's stuff in it, right? So that's going to be our collecting duct. So you can look at all three of them next to each other. The clear one is the loop of Henle early on in the nephron. The vasa recta is going to have red blood cells, runs next to the loop of Henle so that they can have that countercurrent exchange. And then once you get to the end, you have the collecting duct, which is going to have like this dirty lumen. You can see there's kind of stuff in it, okay? And you can compare them here. These yellow lines, you would say that's more of a dirty lumen. So that would be our collecting duct. This clear area next to it would be our loop of Henle. And anywhere you see red blood cells will be your vasa recta. So that's the 5 things I think they could ask you. Differentiate between a proximal or distal convoluted tubule, and looking at the longitudinal cut, are we looking at loop of Henle, vasa recta, or collecting duct? Okay, so you could do those 5, you should be good. This is just a zoomed in view. Dirty here, so that's collecting duct. Clean here, loop of Henle, red blood cells, vasa recta. Piece of cake. All right, now when we get into the urinary system, that uteric bud that formed embryologically, you get into that drainage point. then we are talking about specifically this transitional epithelium. The only time you find transitional epithelium is in this urinary system. Okay, so if they're ever talking about that, you have to be talking about the ureters to the bladder to the urethra, that area. And you can kind of see it here. They have, well, this is, I think I have a better picture of it coming up. Yeah, but this is this transitional epithelium. It's kind of hard to differentiate this from like the pseudostratified and whatnot. Ideally in the stem, they would tell you you're in the bladder area and then you automatically know it's transitional, okay? And then the ureter, it has this, they call this a stellate shape, but it'll have this transitional epithelium as well. You can see the muscularis, the three components to it, ending with the muscularis and the adventitia. And then you get to the bladder, and this is where I wanted to point out, they have these, what's called these umbrella cells, okay? They kind of bud out into the lumen. And the reason this is like this with this transitional epithelium, the reason this is like this is because when the bladder's full, the lumen expands, right? So these umbrella cells get pushed out. So a lot of times they like to talk about these because it's very specific to the bladder. Okay, then we get to the urethra. Still, we have transitional epithelium all the way to you get to just the tip over here. And then you have stratified squamous, and it's kind of towards the outside. So just keep that in mind. All right, glomerular filtration. So some of this math does get a little complicated, but we're going to try to keep it straightforward in your head. So GFR that's what they measure. That is going to be an indication of how well you're filtering all of the blood, how well you're filtering the urinary system. So it has to do with the pressure that you're forming, the change in pressure, along with this coefficient. So they use, well, we'll get there in a second. Now, this is a super important concept too, okay? So you have different pressures that go to and from the capillaries and the Bowman space. So the first pressure we're going to talk about is hydrostatic pressure. Now, that is just the outward pressure of the fluid. So anytime you have fluid in a tube, it's going to push an outward pressure. So if we're in the capillary here, this hydrostatic pressure is going to be trying to push out, okay? Push out into Bowman space. All right, anytime hydrostatic pressure, you're pushing outward. But there's also something called oncotic pressure. So in this capillary, you have these proteins that are charged, okay? They're gonna have a pulling effect to hold water in the capillary. So you have these opposite effects. The hydrostatic pressure is gonna be pushing fluid out of the capillary, and the oncotic pressure is gonna be holding fluid and pulling fluid into the capillary, and they have to work together. Now, this is also true for Bowman space. Get a different color. Bowman space is also going to have a hydrostatic pressure pushing outward, and Bowman space is also going to have an oncotic pressure pulling fluid into the space. All right, so there's a delicate balance, and we'll look at some of the problems that can form if this balance is not intact. So you have a balance between the hydrostatic, between the capillary and Bowman space, and you also have a balance between the oncotic pressure, capillaries versus Bowman space. All right, so pushing and pulling, that's what we're thinking about here. All right, and okay, I pulled this equation out of first aid. The ones in lecture it's the same thing, they just have the values in different places. I like this one because this is easy for me to remember. It's all the same. You could like work it out to be the same. So first off, you can just subtract the hydrostatic pressure in the capillary versus minus the hydrostatic pressure in the interstitium. Easy. And it's all negatives, right? The one in lecture that they use has negatives and positives. I think this one's easier to remember. So you subtract those, you subtract the minus, and then you can subtract the oncotic pressure in the capillary versus the interstitium. What trips people up is these are coefficients, both this one and this one. If they don't give you the coefficient in the stem, you assume it's 1, okay? That makes sense. But Use whichever one you like. I just like this one because I can keep my hydrostatics together, I can keep my oncotics together, and we're using all negatives. So yeah, that works. But make sure you know this equation because it's going to come up again and again. All right. Yeah, so right. So through this process of using hydrostatic and oncotic pressure, you're able to filter and reabsorb the urine from the blood. Okay. Let's see. Yeah, and it just talks about it. It's the same thing. This is just in words what this equation is. Okay. So between the pressures that we're talking about, we get an overall push of the urine into Bowman space. And you could see I put it again here. But oh, this must have been the one from lecture. So whatever you want to do, if you like this one better, do that one. This just makes more sense to me. So I like that one. All right, now you might say, oh, the hydrostatic pressure, just that makes sense. Everything's pushing. Like, what's the big deal about having these proteins in the actual capillaries? Like, it has a pulling effect. Well, it's a big deal, right? Because albumin, which is a very large protein, its main purpose is to have that oncotic pressure in the capillary. Okay, it's huge. It's too big to go through the glomeruli to be filtered, so it stays in the blood. Now, people that have liver failure or protein malnutrition, stuff like that, they don't make enough liver protein such as albumin. Now, what happens? Well, you can't hold the fluid into the capillary, right? So if we have our capillary here, in this kid, right, this is called ascites. So he has what's called nephrotic syndrome. You'll learn more about that later, but this is what you need to know. You're putting too much protein in your urine, which means he has decreased protein in his capillaries. Right, you get it. Right, so decreased protein in his capillaries. So the hydrostatic pressure pushing out is overwhelming, right? You don't have this pull because of our decreased proteins. So what ends up happening, the hydrostatic pressure overwhelms it. You can't keep the fluid in the vessels. Okay, so you end up with what's called ascites. All of this is extracellular, in the interstitium. This is interstitial fluid. And the whole point is that he's dumping all these proteins into his urine, including albumin. So therefore, his oncotic pressure is extremely low. So saying increased oncotic pressure in Bowman space is the same thing as saying there's a decreased oncotic pressure in the capillary. Okay, make that make sense to you because this is a super important concept, all right? That oncotic pressure in the capillaries is a big deal. Primarily, we're talking about albumin. If it's not there, you're gonna push all of the fluid out into the interstitial space. Without that albumin in the protein, you can't hold the fluid into the capillaries, okay? So it's all going out. Cool. I don't have the chat up, so if y'all have questions, y'all can just say it. All right, you cut me off, it's not a big deal. Right, so look at this dilation here. Cholelithiasis is the medical term for a stone, okay? So you get stone formation. This is probably lodged, it must be lodged right here in this uteropelvic junction, right? Just like at the image we saw earlier. So you could see this backup, this dilation, which could lead to hydronephrosis. Now, in regards to this, if you have a backup of fluid, you're also going to be increasing your hydrostatic pressure, right? If you hold the end of a hose and you're pushing fluid through it, you're going to increase the pressure of that fluid in the tube. So therefore, you're going to get increased pressure. So a lot of this fluid is going to end up in the interstitium, right? A lot of hydrostatic pressure, okay? And this is a very important equation here to know. Filtration fraction, it should make sense to you, right? Is everything that the glomerulus filters versus the renal plasma flow or the blood flow going through it. So yeah, it was right, that was right. So you filter about 1/5 of the blood that comes through at a time per cycle. So the amount filtered is the amount the glomerulus filter, or the percentage, right? The fraction is going to be the amount filtered over the total plasma or blood flow. Okay, so this is super important because you can determine how much blood is going through and how much you're actually able to filter. So know it. Okay. All right. So just in a general sense, this should make sense to you. If you have vasoconstriction, you're making the tube smaller, the flow decreases. The point, but what they actually talk about is afferent versus efferent constriction, because it kind of changes things. But in general sense, vasodilation, you have the lumens larger, so the flow can increase, right? More urine or blood can go through it. But this is the point I want to explain. Now, let's say, which one I want to do first? Okay, let's say we constrict the afferent arteriole, right? So blood is going to go this way, okay? Yeah, blood is going to be going this way. Now, the glomerulus is down here, you could see. Now, if we constrict the point over here, make this smaller, overall blood going through this process is decreased, right? So overall blood going through the glomerulus is decreased. Therefore, you're going to get a decreased GFR. So the body can do this on its own. It can, if it wants to decrease the GFR for whatever reason, you can constrict the afferent arteriole, so that decreases the blood that's going to go through this portion, okay, in between the afferent and efferent. Now, what if we did the opposite? Let's say we constricted the efferent arteriole, okay? So blood, a lot more blood is able to come through, but we have a constriction point. We constrict it over here. So the only place the blood is able to go through is through the glomerulus, okay? It can't, it's constricted at the end point over here. So you're forcing the blood to go through the glomerulus. Therefore, in this sense, if we constrict the efferent arteriole, we're going to increase our GFR. Okay, so if the body senses it needs to filter more, it can constrict the efferent arteriole. Okay, hope that made sense. All right, and this kind of just puts everything in order. Just kind of walk through this process. They love these questions, which are a pain on the test, A, B, C, and D, and a bunch of up and down arrows. You will see these on the exam. So make sure you can differentiate the different processes. These two, the pressure and the flow, can be calculated with our filtration fraction. So just make sure you could do those. All right. Now, there's a couple of different processes here. First, anything that comes through the glomerulus is going to be filtered. Now, from this point, what would you call it? Okay, let's say we're in the loop of Henle here. Well, I mean, proximal convoluted tubule, let's say we're a little bit further down, loop of Henle. This peritubular capillary is going to be our vasa recta. Okay, we said that this vasculature that runs to the side of it is going to, they're going to have this counter current exchange. So first, you're going to filter the blood through the urinary system, but sometimes you can actually reabsorb stuff that goes through and put it back in the blood. So let's go back and let's use the proximal convoluted tubule as an example, PCT. If at any point you filter protein, P, or let's say glucose, amino acids, stuff like that, and it gets filtered, 100% of it needs to be reabsorbed. Resorbed and reabsorbed are used interchangeably, all the same. Okay, so you could say that some of the protein may be filtered, some of the glucose may be filtered, but it is one of the major jobs of the proximal convoluted tubule to reabsorb all of that. You want to keep it, you don't want to pee out protein and glucose. Okay, so we talked about two of the processes. Now, let's say stuff doesn't get filtered for whatever reason. It goes through the vasa recta, and it can also be secreted from this point. Okay, so secretion is from the capillary, the vasa recta, back into the urinary system. And then, of course, whatever gets through the whole system is urination, is excretion. Now, this is the overall equation you need to remember. Anything that's filtered that comes through here that's not reabsorbed minus the reabsorption and is also secreted. So you're counting everything that got into the urine, not this though, okay? So just make sure you know this, and that will total our excretion, okay? So this minus, so anything in the urine, what's filtered plus what's secreted minus anything that's reabsorbed. All right, they may ask you to calculate that. I think that Dr. Chilipilla had a whole lecture on that. Okay, so we can use certain molecules that have certain characteristics to determine what's going on. So these are going to be important to remember. Inulin and mannitol, none of them are there. Whatever is filtered is excreted. So what does that mean? Is any of it reabsorbed? No. Is any of it secreted? No. Okay, everything that's filtered will go straight through and it will be excreted. So they don't typically use these, but if you were, this is more theoretical. You would expect this to be the case. If there's any deviation from this, maybe there's an issue. Okay, net reabsorption. Now we talked about this. Glucose and sodium, you're going to want to bring it back in. Also proteins. Urea is tricky. We'll talk about that in a little bit, but they actually use that to help with the countercurrent exchanger. But at the end point, you actually end up peeing it all out. So these are going to be our things that are net, have net reabsorption. So whatever's filtered is going to be more than what's excreted because you're reabsorbing it back into the bloodstream. Net secretion. So you would expect some of this to get through the glomerulus, and it's not going to be filtered, but it'll get into the vasa recta and it'll be secreted. So PAH and creatinine. Now, creatinine is the big thing that they use to determine your kidney function. So you can look at it on a graph, and it works the same. It's an easy measurement to see what your GFR is. You could calculate it. So it should be 1. In a normal patient, it should be 1. And they use that as a measurement just because it's standardized. So if you ever see that in the hospital, they check the creatinine. If it gets to 2 or 3 or 4, you're thinking a decrease in GFR and renal failure. So that's actually, it's just some of the other molecules are better, but this is just easier, and it works out to measure. It's a breakdown product of creatine in your muscles, and so it's just standardized in people. It should be about 1, but again, if it's elevated, it could be indicative of renal failure. All right, so yeah, you can look at these equations and see transport filter load minus excretion rate, or look at these here. I think I have more on this later, but you could kind of determine what our transport rate is times by using these values, but I think I have more coming up on that. It was done in a different lecture. I think this was the DLA. All right, and then, yeah, you can determine these equations, and if you work through this equation here, it's a good way of determining filtration fraction. If you could do it like this, you pretty much do it on the exam. That's about as hard as they can make it. All right, and then anytime renal blood flow, they kind of use these interchangeably, but if you really wanted to calculate renal blood flow, you use hematocrit, which is the density of the red blood cells in circulation. So renal plasma flow over 1 minus hematocrit is going to give you renal blood flow. But just remember let me go back, when they do filtration fraction, they use renal plasma flow. Remember, the red blood cells don't count towards this. You're worried about plasma, the smaller stuff. All right, so, but if you wanted to calculate renal blood flow, you could do it that way. Sometimes what they'll do, they'll want you to calculate filtration fraction, right? And they won't give you renal plasma flow. They'll give you renal blood flow and the hematocrit. So you have to use 2 equations. You have to use this renal blood flow using the hematocrit to find the renal plasma flow. And once you find the renal plasma flow, you can figure out the filtration fraction. Okay, I've seen that before. Y'all might have run across practice questions like that. All right, and then you've talked about this in FDM and stuff, this transport mechanisms, facilitated diffusion, like our GLUT transporters, right? And then we have simple diffusion, just open a channel and it goes down its concentration gradient. And then those SLT transporters are like active transport. Okay, so primary versus active transport. Remember that anytime it's active, active just means it uses ATP. Facilitated or simple diffusion, it doesn't. It goes down a gradient. Anytime you have active, you're using ATP. The main one we always talk about is this sodium potassium ATPase. Okay, so if we look at this here, this would be primary versus if it uses a co-transporter such as this, it can be secondary transport. All right, so this becomes a pain because it's very complicated, but they really don't test you too much right now. When you start talking about some of the diuretics, the drugs that they use in term 4, then you talk about a lot of what goes on at each area. But for right now, y'all really just need to know the general idea of this. So like I mentioned earlier, the proximal convoluted tubule, you are going to try to reabsorb a lot of those amino acids, proteins, your glucose, stuff like that, pull it back into circulation so you don't pee it out, so you can save it. That's the primary role of that proximal tubule, glucose and amino acids. So diuretics will help to help you urinate. That's what diuretics do. If you can increase urination, you can decrease blood volume, therefore decreasing blood pressure, okay? This is a very common thing. Patients that have whatever, primary hypertension, kidney failure, a lot of heart patients, we're worried about hypertension, so we have to get them on diuretics. It's usually a first-line treatment, but again, y'all will get into a lot of these later. Waters follow sodium, always. Okay, loop of Henle, then we start talking about when we're transporting this water sodium gradient. So as you go down the loop of Henle, it goes through sections where only sodium is able to cross the membrane, and then other sections where only water is able to cross the membrane. And this is the way of having a counter current exchange. You're kind of checking yourself, right? So if only sodium can get through, it will equilibrate there. But then when water can get through, it will equilibrate the water at that point. So as you go through, it kind of titrates your system as to, by the end, get rid of the exact amount of what you need. Again, it gets really complicated, so y'all really don't need to know this at length now. And then also, one of the things it's good to remember is some things are transported between the cells. You can see that calcium and magnesium, peritubular transport, those will go through as well, but they don't actually go through the cells. These use, again, this is more term 4 stuff, but like this NCCK channel. So it's going to use sodium, chlorides, and potassium, and everything's going to be transported there. Now, one of the things about the distal convoluted tubule that's important is that's the primary site where PTH works. Now, you've learned kind of sort of about PTH. I'll get to it more when y'all get to endocrine, but PTH is going to be responsible for increasing the calcium in your blood. Okay, so if you have increased PTH on these channels, you're going to bring back calcium, and it's going to get into the blood. Once again, this is more of a term 4 issue, but they use thiazide diuretics here. One of the problems with thiazide diuretics is they can lead to hypercalcemia. Okay, you'll get to that later, but if that helps you remember that that's where these channels are, then so be it. Okay, so you can walk through this process. If you have a decreased GFR, a lot of times that has means decreased pressure, decreased fluid going through, decreased fluid being filtered. Then at that point, this should also correlate with decreased sodium at the macula densa. Again, hypovolemic, right? Low volume is these two processes, you see? So what do you do if you have low volume? You increase renin. Renin's going to increase angiotensin 2. Remember that enzyme we talk about here, it's a multi-step process, but that main enzyme we talk about here from angiotensin 1 to angiotensin 2 is, is ACE. Again, this is a good pharmacological step because they use ACE inhibitors like lisinopril. But that's going to help to convert angiotensin 1 to angiotensin 2. So again, what does angiotensin 2 do? It's going to tense down on the vessel, so it'll increase your blood pressure. What happens if we, what happens if we increase our efferent arteriolar resistance? Now, we talked about that. If the afferent arteriole is large and you get to a point and you constrict the efferent arteriole, right? And then blood's going through here, use a different color. But blood's going through here and you have a constriction point over here, you're gonna force blood through the glomerulus. So you're gonna increase GFR, okay? So that's a good thing because this is going to help to correct this. Yes, we're going to help to increase our GFR. So pressure is going to go up. Oh, you can see that here. Pressure is going to go up and we're increasing our GFR. All right. And then the opposite is also true. If you have too much volume, you should also correlate with too much sodium, right? They go together. Adenosine, not super important, just know it's a vasoconstrictor, but it'll help to vasoconstrict the afferent arteriole, right? And we said that if we constrict the afferent arteriole, no blood's gonna be going through. So we have a small, and it's small over here. So no blood's really gonna go through because it's a smaller tube. So therefore, we are decreasing our GFR, decreased pressure, decreased GFR. So you may have to sit with that, just talk it out with your friends or in a mirror or whoever, to your grandma, don't matter. Just make sure you can understand this. All right, now when you get to the late distal tubule and you get into the collecting system, there's a couple of things. These principal cells, they have aldosterone receptors, but they also regulate ADH. I don't know if y'all talked about ADH yet before this, but remember we said aldosterone will help to have these channels. These are intracellular aldosterone channels, but they help to bring sodium back into circulation. If you bring sodium back, you're bringing fluid back, water back, so you're going to increase your blood pressure. Anti-diuretic hormone. What is a diuretic? Diuretic makes you pee. So if you have an anti-diuretic, you're going to prevent yourself from peeing. So these ADH receptor channels, if you use anti-diuretic hormone, you're going to open these channels, which will pull just water through, okay? And that, when you start talking about the pathology or the problems that form, it's different. So just keep in mind, the whole goal between both of these is to increase blood volume. Aldosterone is going to use sodium, right, to then bring in water. I should use my iPad, right? But these antidiuretic hormones are basically just water channels, these V2 channels, or V1 and V2 channels. So it's just going to be primarily water, okay? Selective for water. But the whole goal here is to increase your volume. So keep in mind, we're talking about these principal cells that do that. There are more channels as you get to the collecting duct with ADH and stuff, but they talk about it in your lecture here in this late distal tubule, right? And you can see that here also, aldosterone. So now, okay, I should explain this since y'all touched on it. So if you have increased aldosterone, okay, so hyperaldosteronism is called Cone syndrome. If you have it, then you have increased sodium coming through. We'll take a break in a second too. Okay, you're keeping increased sodium or in the circulation, which means you are putting more potassium in the urine. Okay, so so if you're keeping sodium, you're getting rid of potassium. But this is a pathological problem, so it's not regulated. There's no equilibrium. So the body's going to want to bring back this potassium. Once you get past these aldosterone channels, it's going to want to bring back potassium. And the only way it could do that, just you're never going to fully correct it because you have hyperaldosteronism. So you're going to be dumping a lot of potassium in your urine. But the only way it could try to do it is to exchange it for hydrogen later on in the tubule. So if you're trying to bring back the sodium, bring back the potassium later on in the channel by getting rid of hydrogens, you can see why you can get metabolic alkalosis, right? Because you're dumping hydrogens into your urine as well. So if y'all come across this, this is that paroxysmal aciduria. That's the concept. It's like, why, if I have metabolic acid alkalosis, why am I peeing so much acid out? You think you would keep it in, but the problem is here, right? So again, you're keeping sodium in circulation, which means you're peeing out more potassium. The body senses that and it's like, oh, we need to try to bring it back. Let's try to transport it for a hydrogen. Then you're peeing out a lot of hydrogen. So overall, you get this metabolic alkalosis. When we talk about the acid-base issues in a little bit, it'll make a little bit more sense. Okay, and this is just kind of explaining where everything kind of works. We kind of talked about these. You'll worry about these drugs a lot more in term 4. All right, that's a good spot. We could take a break. We'll take a 5-minute break, and if y'all have any questions, just let me know. All right, let's go. Body fluids. Love them. All right. All right. This is important to know always. Your interstitial fluid, or I'm sorry, your intracellular fluid will make up 2/3 of all the fluid. Extracellular will be 1/3, and of that, you can break it down. 1/4 is plasma, 3/4 is interstitial. So by giving you any one of these values, you can calculate everything. Okay, so they'll probably do that for you guys. And this is just more in words, how things break down. Good thing to note, total body water. I think they gave us just a question like this. You just had to know that in minutes. 60% women's, usually 50 to 55%. So remember these, just they may give you just a straight question and ask you, give you the guy's weight and tell you how much body water, or give you the body water and ask you how much he weighs. So definitely know that. Let's see, blood volume. Yeah, plasma volume, 1 over hematocrit. That's like I said earlier, they may give you the blood volume and not give you the renal plasma flow or your plasma volume, but you can calculate it that way. All right. Now, we mentioned some of these in context to what they actually do. So being that the characteristics of inulin and mannitol are freely filtered, so they're all excreted, it correlates to being able to calculate an ECF, your extracellular volume. So what I would do for this is know each of these and what they correlate to, okay? Because they can give you certain variables and ask you to calculate a different variable. So for instance, they can give you titrated water here and also give you inulin, and then they could ask you of that, what's your intracellular fluid, okay? So it can get a little tricky, but as long as you know what correlates with what, you can figure out some of the things that aren't so intuitive. Okay, let's see. Yeah, I don't know if they'll give you this on the exam. Yeah, I think I put this in there for completeness sake, but this is just externally if you inject fluid, like IV solution, injected versus excreted over your concentration. In plasma, this is how you would do certain tests like this. You inject it in, see what they pee out, and you can calculate things. All right, now, this gets complicated too, but I'm going to explain it to you in context of like just what you need to know for the test. Because if you start breaking it down into little sections, it gets even more complicated. So if you look at isoosmotic, right? So you're not changing. It's not, so hypoosmotic and hyperosmotic, you're changing the solution. Remember when we talk about osmotic, we're talking about particles, right? So hyperosmotic means there's increased particles in it. Hypoosmotic means it's more dilute, okay? So isoosmotic, isotonic saline or isotonic sodium chloride is just like your IV solution, 0.9% or 0.9% sodium. So you would expect the volume expansion to be about the same. You can see here you have a little bit of increase in volume of your extracellular fluid, but you're not changing this y-axis. Now, for instance, if you're adding solution, so a lot of sodium chloride, so older patients, if they eat a lot of salt, they'll start to swell. This is stuff like that. So you can see the particles is going to correlate to your y-axis. I have a better slide coming up in a second. But so if you increase this y-axis, you're contracting your overall water volume, but increasing the amount of solutes in concentration. Okay. And then hypoosmotic, syndrome of inappropriate antidiuretic hormone. So if you're preventing yourself from peeing or diuresing, you're increasing the fluid in your body, or sorry, not the fluid, but the water, the actually pure water in your fluid. So in that case, you can see that we're actually diluting the system. You're decreasing this. This decreasing particles in solution is going to decrease your y-axis. And again, increasing particles in solution is going to increase your y-axis, okay? Now I'll show y'all a little bit better. Oh, I didn't hear, never mind. Okay, increasing osmolarity will be your y-axis. So if we have isotonic saline, you're not changing your concentrations, right? That's okay, so just break it down. Like isotonic saline is the normal saline, the saline bags they hang in the hospital. That is exactly what your body's supposed to have. Okay, so you don't want to just give pure water or extra salt. If you don't have to, you want to keep everything in equilibrium. That's why this y-axis isn't changing. Osmolarity is solids, is particles in solution. So if you have a lot of sodium, that's a lot of particles, you're changing your y-axis. If you have increased water intake, this is pure water, okay? This is a concept where this disease will cause you to keep pure water. You would consequently decrease the amount of solutes or particles in solution, right? So if you go above here, like you see, of the y-axis, you're increasing particles, increasing your osmolarity. If you're just adding pure water, you're going to dilute the system and you're going to have decreased osmolarity. Water is going to correlate to your x-axis. So you're not changing here, you're not changing the actual solute, you're keeping that at equilibrium, but you are adding fluid. You're adding overall fluid. So you're adding volume. So you're going to change this here. Again, what ends up happening is when you increase your solutes here, you just get a shift over. Again, that's not terribly important. The idea here is this is actually more complicated than it's taught. So I just want you to focus on the things, these axes that I have. And again, if you're increasing pure water here, you diluted the system, but you have increased the overall water. You see you have an expansion outward on both sides. All right, so we're going to talk about this again in concept of different situations, and that'll make it easier. So if you have diarrhea, you tend to become dehydrated. You're losing a lot more fluid and water than necessarily the particles in solution. So think of diarrhea causing dehydration. What would you expect here? Well, you would expect on our x-axis, which correlates to water, you would expect volume contraction, okay? Because we're losing overall volume, okay? Now, take water deprivation, what's gonna happen? You are also losing water, but the concentration of particles in your solution is gonna increase. It doesn't actually increase, but the percentage increases because you're decreasing the water amount. Okay, so it looks like the concentration goes up, your osmolarity will go up just because you haven't had any water. So you're going to get volume contraction, but the actual particles in solution will seem elevated because you lost water, right? The reason you don't get that in diarrhea is because you do lose particles too, but overall it's a decrease in water, right? Now, if you have adrenal insufficiency, you're not, so for example, you're not going to have aldosterone, so you're going to get a decrease in particles and this intracellular fluid expansion, so a shift intracellularly. I think I have another slide coming up. Okay. But you can see here with adrenal insufficiency, you're not able to hold on to water. Okay. So if this is confusing for you guys, it still makes my head spin sometimes thinking about it. But just kind of remember what correlates with what. Diarrhea, you're getting an overall dehydration, but you are going to lose some particles in it, in the fluid. So you're just going to get a little bit of volume contraction. If you're losing free water or you're not drinking free water, the concentration of the particles is going to be elevated. So you would get this, the osmolarity is going to go up on our y-axis. And if you have adrenal insufficiency, you're going to lose water primarily because of aldosterone. Okay. Now you can see that here, same principle. We talked about, again, water deprivation here. The particles seem like they're more because you don't have enough water in your system. Diarrhea, you're going to get dehydration, so overall fluid loss. Okay, so just kind of, if you can correlate what goes with what, it'll be easier. Honestly, as for differentiating intracellular versus extracellular, you really don't need to too much. You'll be fine on the exam if you don't worry about it, as long as you know, basically, are you going to have an overall increase in particles in solution or overall increase or decrease in water? You should be fine, but they won't ask you to differentiate intracellular versus extracellular. I think we had like 1 or 2 questions on this, so it's not too bad. And like I mentioned, isotonic saline is going to be your normal concentration in your body. So that's 0.9% sodium chloride. Is going to keep everything stabilized. Dextrose is a component of glucose. So if somebody comes in and their blood glucose is low, you can give them dextrose, but you really don't need to correlate. Maybe just know that 0.9 is isotonic and 0.45 would be half that. And then I put a star on this slide. These are going to be important. Again, the weights, the males versus females, blood volume, we talked about that one. Intracellular and extracellular, we talked about that. And then how extracellular breaks down. 1/4 plasma, 3/4 intracellular fluid. I'm sorry, interstitial. Sorry. Wait, that should be interstitial, right? Why does that say intracellular? Interstitial fluid, yeah. I don't know why this is like this. So it should be intracellular fluid is 2/3, extracellular is 1/3. Of this 1/3, plasma is going to make up 1/4, and interstitial fluid is going to make up 3/4. Am I wrong about this? This should be interstitial fluid. Can we confirm? Yes, is that right? It is. Okay, cool. Just making sure. All right. Let's see. Give me 1 second. Look at this. Okay. Serum proteins. I think Dr. Trotz did this lecture. So albumin's going to be your initial big peak, and then your different globulins are going to correlate. This is some cancers such as multiple myeloma. They use this this analysis to kind of dictate what diagnostically what's going on. So I think it's important to know what falls into what category. Okay, because what they'll give you on the test is something different from this normal curve, and they'll say what's going on, what could have been lost, is there some sort of acute infection? Remember that last gamma peak is going to correlate with the immunoglobulins. So with some sort of infection or whatnot, that could correlate to, it could either correlate to some sort of increased infection, or if you have multiple myeloma, it would be increased, or if it's decreased, maybe you have some problem with B cells and forming your antibodies. Okay, so this is an important, let's just break this down. So what happens if we can't make albumin? What did we say? Albumin is going to be very important in oncotic pressure. Oncotic. It's so hard doing this with the mouse. All right, oncotic, right? So that's going to hold the fluid in the vessel. So if we're not making albumin, look at this, kids' ascites. All that hydrostatic pressure pushing out is going to overwhelm the fact that we can't hold the fluid in. Kwashiorkor is a dietary deficiency of proteins. You don't have proteins, you can't make albumin, so you have decreased oncotic pressure. Liver cirrhosis, also, if your liver doesn't work, you're not going to be making a lot of proteins, right? Now, you can also have a different problem where you're losing albumin. Kidney disease, you could see a lot of protein, and that primarily is at the level of the glomerulus, that basement membrane. If those little holes get too big, the albumin can go through it and you can pee out albumin, have high protein. Look at this lady's face, you can see that swelling. Again, you don't have oncotic pressure, so all the fluid's going out into the interstitium. Also, severe burns can lead to that as well. Right, so that's what you would expect, edema and ascites, because all the fluid is leaving the vessels. You can't hold on to it because you don't have oncotic pressure. All right, we did discuss this when we talked about the pulmonary system. Remember, neutrophils are going to make this elastase, and alpha-1 antitrypsin makes anti-elastase. So alpha-1 antitrypsin will help to neutralize this elastase coming from the neutrophils. Smokers tend to have increased neutrophil elastase. So if someone has alpha antitrypsin deficiency, you can't really fight it off. So they would get increased elastase, and it's the goal of alpha-1 antitrypsin to kind of block that. But if you don't have this, then you can't properly neutralize the elastase. Therefore, you're going to get a breakdown of the lung alveoli, okay? Now, remember I told you that a good trick on the exam is to differentiate this from emphysema, is alpha-1 antitrypsin disease, excuse me, also causes liver failure, okay? So if they talk about a patient, it seems like they have emphysema, they're a smoker, they have, COPD, they have, obstructive lung disease, but then they also say, and they have liver failure, right? So then you're saying, oh, maybe it's this, maybe it's alpha-1 antitrypsin. But a lot of times they'll specifically say there's no signs of elevated liver enzymes, there's no liver failure, and so you can rule this out. This has to have both components, liver and lung problems. All right. This is more the genetic breakdown of it. Serine protease inhibitor. That's the gene, if it helps you remember it. All right, and then, Dr. Sobring went through this. MM is your normal isotype formation or your genotype formation. ZZ is the worst that could form. But again, remember, not only do you get lung problems with that elastase, you also get hepatocellular injury, so liver failure. And yes, this is that mutant allele. All right, so smoking can lead to emphysema. If you have alpha-1 antitrypsin disease and you smoke, you will get signs of emphysema much earlier, or signs of destruction of the alveoli much earlier. But remember, like I said, if it's alpha-1 antitrypsin disease, you're also going to get lung problems. Okay. And this is just one of those weird things. And Dr. Sobring likes the idea of this. So you get a loss of function because you can't protect, you don't have this anti-elastase that can protect from the neutrophil elastase, but you also have this novel function. So you get a loss of function plus this new or a gain of function mutation, because it's going to lead to hepatocyte damage and cirrhosis. I don't know. He likes testing on these things with this loss of function plus gain of function thing. So just keep in mind, it has to have both. Now, alpha fetoprotein is you'll see that a lot of times if there's a neural tube defects, this could be elevated. You can also see this with hepatocellular carcinoma. It's a tumor marker, but so yeah, that's all you really need to know for that. Yeah, you can see this. This is some sort of meningiomyelocele, it looks like. I can't really tell, but you could see lots of time this is because of low maternal folic acid, but these will lead to increased alpha fetoprotein. Very importantly, if you ever see low alpha fetoprotein, that could be indicative of Down syndrome. So they're opposites. Increased alpha fetoprotein, neural tube defect, decrease could be Down syndrome. All right, cool. Wilson's disease. Now, this is that ceruloplasmin. What they talk about a lot of times. So the problem here is that you can't get copper into bile. So copper ends up going everywhere else. You're supposed to get it into the bile so you could process it. If you can't do that, you get copper deposits everywhere. They like to talk about these Kaiser-Fleischer rings that form around the eye. That's a dead giveaway that it's Wilson's disease. But in regards to our little plot we were looking at with the peaks, we're talking about this ceruloplasmin. That is the transport form of copper to get it into the bile. So if you have a problem with this ATPase, you can get Wilson's disease. And now when we talk about the gamma globulin, I mentioned that that's the formation of our immunoglobulins, all of our antibodies. So any sort of deviation from the norm here can be indicative of infection or multiple myeloma or whatnot. Here's a perfect example. Understand that it's a monoclonal gammopathy, which means that if you say, okay, this is way high, what's going on? It's monoclonal, which means this spike will only be one antibody. So you'll get increase in just say IgG, right? Monoclonal, right here. I don't know why my cursor's not, there we go. So it's monoclonal, so it'll be like a gamma globulin spike of just one. So this huge peak is caused by a single type. So that's important there. If there are multiple types, it could be an infection or something else going on. But this is the classic example they give for that. Okay. Now, this is also important because sometimes when you have an infection, or when you do have an infection, some sort of acute phase infection, you're going to want to upregulate certain proteins and downregulate others. So you need to commit these to memory. These are the ones you're going to upregulate, and these are the ones you're going to downregulate. So if you look at the peak and someone has an infection, and you would expect that initial rise in albumin, it may be decreased just because they need to sacrifice making albumin to make some of these players to fight off the infection. Now, C-reactive protein isn't categorized in this, but if you ever measure C-reactive protein, it's very nonspecific, but it does mean there's some sort of inflammation going on. So yeah, it's a stress response. Super important slide. If you understand this slide, you will be able to answer your questions on the exam. Now, acute inflammation, look at this. We decreased our albumin a little bit to upregulate some of the other players. Liver cirrhosis, you are going to start decreasing your albumin, which means you probably end up with ascites, right? Because of that decreased pressure. But one of these weird things that form is this bridge, this beta gamma bridge. If you ever see that, that's indicative of a polyclonal gammopathy, right? So you're making a lot of different immunoglobulins. But if you see this bridge that forms, it's usually due to liver cirrhosis. Multiple myeloma, this will be monoclonal, so maybe just IgG spike. Nephrotic syndrome, what does that mean? You're losing proteins in your urine, so that's decreased albumin, and you're in a constant state of stress, right? The body's in a constant state of stress. So you're gonna upregulate other things. Hypogammaglobulinemia means you're not making antibodies, so probably some sort of B cell dysfunction. You can't make antibodies. And of course, classically, if you don't make alpha-1 antitrypsin, your initial peak here will be decreased. So just walk through these and you'll be able to answer the questions. All right, we've talked about this a little bit already. So just keep in mind, you're in a constant state of equilibrium. So you're regulating your sodium and just so you could regulate your volume. And primarily by titrating your sodium, you could regulate how much water you have. Okay, so we use renin, aldosterone, renin, angiotensin, aldosterone of the RAS system. Plus you have renal nerves that will correlate to vasoconstriction, vasodilation. Starling's forces are just going to be those hydrostatic and oncotic forces, just pressure. And ANP is from the heart, atrial natriuretic peptide. So it kind of works in an opposite of the RAS system. So it senses hypertension. So if the heart is under stress, because there's a lot of blood coming through it, you can release ANP and it'll help to decrease the overall blood volume. Right, and baroreceptors are, you're going to get into this much more later, but it can regulate your blood pressure, typically in response to standing up or laying down, just to regulate vasoconstrict or dilate. But it can also, secondarily help with renin release. Again, remember we said the macula dense is going to regulate or monitor your sodium, and so it will be an important way to help to release renin, which is from this JGA, this juxtaglomerular apparatus, will help to release renin. And again, starlings are pressure. If you have hypertension, you're putting extra pressure. If there's extra pressure, those hydrostatic forces are pushing fluid everywhere. Okay, so the point is there's a lot of different mechanisms to correspond to it, because regulating your blood volume is a systemic process. Okay, now we talked about this, right? Renin. The body notices low blood volume, low blood pressure, release renin. Get to angiotensin 2. Remember, ACE is our major enzyme there. Angiotensin will tense down on the vessels, then activate aldosterone. Aldosterone will bring back sodium, which will also bring back water. So twofold effect. We increased our blood pressure and increased our blood volume. And that's the goal. All right, and this just breaks down where everything is, but we kind of talked about this already. And remember, secondarily, after aldosterone is released to bring back sodium with water, you can also release ADH, which will bring back pure water. These are just water channels. Okay, and this is just from first aid. I like first aid's pictures. They kind of break everything down for you. All right, yeah, and then again, the baroreceptor reflex will help to increase, it actually, well, again, this is a term 4 thing, but it actually works in opposite the way you think. So if you get decreased blood pressure, it'll inhibit the firing effect, it'll increase your sympathetic tone, so it'll squeeze down on your vessels, and therefore it will also activate aldosterone, right? Because this process of feeling decreased blood pressure, you need to vasoconstrict via sympathetics, and you need to also increase your blood volume. Okay, so that's this process. It's always twofold. You want to squeeze down on the vessels to increase your blood pressure, and then you want to increase the blood, the water and sodium you retain to be able to increase your blood volume. Okay. And then this just goes into Starling's forces, but we talked about these in regards to hydrostatic pressure and oncotic pressure. So if you know that equation, this equation, you will be good to go. Again, there's different, they move the variables around in the lecture, but this is the way I like to do it. So it all works out the same. Don't forget that sometimes they don't give you these constants. If they don't, assume it's 1. All right, and then again, first aid just kind of puts everything in one nice little picture. And so you could break it down that way. This is that ANP process. So if you see preload, we talked about that, right? Preload would be indicative that there's too much blood volume. So if you have too much volume in the ventricle before you contract, the body's going to tell itself we have too much volume here. We need to get rid of it, so you can release ANP. ANP will, you don't really need to know why, but ANP will increase sodium excretion. If you increase sodium excretion, you're going to increase water excretion, therefore decreasing your overall blood volume. Okay, good. Again, when y'all talk about a lot of the drugs in term 4, y'all will get into this, but this kind of just tells you where everything is. Super important. Remember, first goal, bring back all of our glucose and our amino acids from proximal convoluted tubule. Then you can worry about titrating the water and the sodium. Remember, distal convoluted tubule, we're bringing back that calcium because of PTH. And then distally, that's where our aldosterone and our ADH will help to get that last bit of water in or out, depending on what is necessary. Okay. It's confusing, but it's not really tested. Okay, so the whole point is that the initial complex after the proximal convoluted tubule is only permeable to water. So you actually get increased osmolarity in the urine, right? Increased sodium in the urine because you're getting rid of only water. And then as you come around the loop of Henle, then it switches, then it's only permeable to salt. So this just titrates it very specifically to be able to get rid of what you need to get rid of. And but you don't need to really focus on a lot of the numbers. They're not going to ask you numbers or anything like that. One of the interesting things is you do want to urinate urea. Urea is a storage form of nitrogen. You don't want nitrogen floating around in your body. It's toxic. But the body actually pulls urea out into the interstitium just so it could help with this countercurrent exchanger. Okay. But once you get down to the collecting tubules, you bring it back into the urine and you pee it out. So if you see it over here and you're wondering, like, I thought we got rid of it, you do. You just pull it out briefly so you can help to use it as a ionic control to for the pressures. I'm sorry, for the concentrations. Okay, now we talk about some of the pathology here. This is super important. It's pretty straightforward. So let's talk about central DI first. Diabetes insipidus. So diabetes is like is like loving. So insipidus is like water loving. Diabetes mellitus, right, is loving of sugar, the M's sugar. So that's what that means. But the point is, if it's central, that means you don't make ADH at all. Okay. If it's at the level of the kidney, that means you have a problem with the receptor. Okay, so clinically, the patient's going to come in the same either way. They're going to be like, I'm always thirsty, I'm always dehydrated. And the problem is you don't have ADH, so you can't bring water back. You pee it out. All your urine is very dilute. You're peeing all the water out. So these patients are going to present similarly. So how do you tell the difference? Well, you give ADH, exogenous ADH, okay? Now, if the patient has central DI, that means they're not making ADH at all. So if you give them ADH, all of a sudden, they're able to hold on to water, which means their urine osmolarity is going to go up, okay? That basically just means they're holding on to water. If it's a nephrogenic problem, the problem isn't that they can't make ADH, it's that the receptors don't respond to it. So regardless if you give ADH, you're not going to get a change in the urine osmolarity. Okay, so that's how you tell the difference. They'll probably ask you this on the exam. Yep. All right. And like I mentioned earlier, they love these charts. So make sure you can walk through these and understand what correlates to what. Very important, these disease patterns. Steph loves this stuff. All right, and then again, some of these equations that may come up, may or may not come up. It's important to know that your concentration of water, if it's positive, you're hypoosmotic, you have less stuff in your solution, okay? I'm sorry, or in this case, in your urine. So you're gonna be dilute if it's positive. More water, positive of water means it's dilute. Negative of water, that means it's very concentrated, okay? So make sure you get this terminology down. All right, and when we talk about this seems worse than it actually is. I think, okay, here we go. Yeah, this is how I break it down. So everything above, the original x-axis is going to be in your urine, and everything below it is stuff you want to keep. So we're starting here at the glomerulus and we're walking all the way down to the collecting tubule. Now, remember we said in the proximal convoluted tubule, we want to bring in all of our glucose and amino acids immediately. We're not peeing it out. We don't want to. So you got to get it back immediately. Then as you walk down the nephron, you're going to start getting rid of different things. So you can see here, so bicarb will go down because you want to get that out, because we'll talk about this in a little bit, but with the metabolic alkalosis, bicarb is going to be abundant. But you can kind of see here, Ideally, like I mentioned before, you're going to want to overall pee out the urea because it's toxic. PAH is going to be freely filtered, so it's freely excreted. So you could see that up here. And then remember, I mentioned creatinine is one of those things that you use to measure GFR. So it should also be excreted. So just knowing where these lines go will help you on the exam. But just keep in mind the stuff you're keeping and getting back into the blood will be down here and the urine's up here. Okay, and it kind of just talks about that. This is the one they use more often to show this proximal tubule. Again, remember, if we're keeping this, we're keeping our amino acids, we're keeping our glucose. For right now, we keep some of the bicarb because we're just in the proximal tubule. And you can see here, we're going to get rid of these things in our urine. Okay. Right, we talked about this process, everything that's filtered and everything that's secreted minus the stuff you reabsorb. That's what's going to be overall excreted. So just make sure you can calculate those. And then some of the equations here, again, they use inulin's more of a theoretical thing. They usually use creatinine, but just make sure we talked about this. They'll probably give you blood flow and hematocrit and ask you to calculate filtration fraction. So filtration fraction is GFR over RPF. So they probably won't give you that. So you need both equations, yeah, to calculate this. Okay, do y'all want to, this is the most important stuff. Should we take a break real quick? Let's knock this out. Now, like I mentioned earlier, this acid-base thing is really highly tested. So we'll kind of break it down and work through these equations. So y'all have learned the Henderson-Hasselbalch equation. Basically, if the hydrogen is attached to the acid, it's not charged, which is opposite for the base. If the base is not attached to the hydrogen, it's not charged. You can see here, hydrogen plus acid is not charged, base plus hydrogen is charged, okay? So this breaks down when we start talking about the different drugs and how they are regulated. So okay. Yeah, so the body uses buffers, primarily bicarbonate, to regulate the change in pH, right? So bicarbonate can be shifted using carbon dioxide and whatnot or carbon dioxide can be transferred with bicarbonate as bicarbonate. And bicarbonate, because it has that, it's in that buffer region with the pKa right around here. I think this is more of a term one problem. You don't really need to worry about it too much now, but because it has a pKa right around this normal range, it works as a good buffer. And you can see that here, they do ask this 20-to-1 ratio of base to acid, this buffering system. So it's good to know that. And then if y'all remember, I might have it, yeah, it's right here. If y'all remember this graph, if we do logs of the pH, every time you change the pH of one, it's a 10-fold increase or decrease. Okay, and that's what's calculated with logs. Okay, so if they ask you about drugs, you know, the trick I use instead of using this whole thing is that if it's an acid and it's in the stomach, which is acidic, you would think it would fall in this range. Okay, so that's how I do it. And so if they tell you an acid and you calculate this and it's say 2 and you know you're in the stomach, you fall in this 99% is going to be absorbed range. Bases are absorbed in the intestine. So if it's a base in the intestine, it would be in this range. I'm going quickly through this because this is just review from term 1. What's much more important is this stuff and the acid bases. So excretion is the opposite of absorption. So for it to be absorbed, it needs to be lipophilic. It needs to be not charged to go through the GI or the stomach or the GI system. But for it to be excreted, it needs to be charged so it stays in the urine. So when it goes through that liver and it does the second pass, It actually puts a charge on it. It's no longer active, and it's able to get into the urine and as an ionized form or a charged form, so it can be excreted. All right. Again, this is just buffering system. Let's see. Okay, so respiratory problems, the main thing to remember here is you treat carbon dioxide as an acid, okay? So if you are hyperventilating, you're decreasing carbon dioxide, right? If you're hyperventilating, you're blowing off the carbon dioxide. So that means you're getting rid of acid, so you're in a state of respiratory alkalosis, okay? If you have hypoventilation, right? So you're not breathing out carbon dioxide as much. You're holding on to carbon dioxide. That means increased carbon dioxide. Remember, we're treating it as an acid, will lead to respiratory acidosis. So the main thing here is just figure out if you're breathing too much or too shallow, and wherever the carbon dioxide is, that is going to be treated as an acid. There we go. All right, now when we talk about acid-base disorders in the kidney, we're usually talking about metabolic problems. So secretion of hydrogens and stuff like that, being able to filter or excrete bicarbonate as well. So this is going to regulate, so primarily the kidneys are going to regulate your bicarb. Now it does take a little bit longer for compensation mechanisms in the kidney, because obviously it could take days for the kidney to regulate this by urination, but whereas you could change your breathing pattern for respiration, second by second. So another thing to keep in mind is that acid phosphate and ammonium are considered acids. So if you have metabolic acidosis or even respiratory acidosis, how do you correct the fact that you have too much acid? You try to pee more acid out. Okay, so if you have chronic acidosis, you try to get rid of that extra acid by peeing it out. Okay, so so what are some situations where you want to get rid of acid? Well, what happens if we're breathing too shallow, right? So we're increasing our carbon dioxide in the body, which means we're not breathing it out. So if we're hypoventilating, that could lead to respiratory acidosis. Also, if we have, for whatever reason, a decrease in pH, which by definition, acidosis, what do we do in the kidneys? We try to increase our acid secretion. We're trying to compensate. We have extra acid for whatever reason. We have extra acid, and by having that, we want to try to get rid of it the best way possible. Okay, we talked about this. This is that paroxysmal aciduria. If you have hypokalemia, the only way to bring back, so that's because you're getting rid of potassium. The only way to bring that back is to get rid of hydrogens, okay? Now, this is what we were saying. This is that cone syndrome, primary hyperaldosteronism. So in this sense, you have too much aldosterone, you're keeping sodium, you're getting rid of potassium. And again, the only way the body at the terminal point can get the potassium back is to get rid of hydrogens, okay? So that'll stimulate alkalosis because you're peeing out too much acid, okay? So again, this is a kidney problem. So this could lead to metabolic alkalosis. If you get volume contraction, we talked about this, we're activating the RAS system. So we're gonna tense down on the vessels. We're gonna also stimulate hydrogen secretion. Again, but this is because of the increased aldosterone. So you can see that here, increasing aldosterone, increased potassium secretion. So you're gonna end up with hypokalemia. To try to fix that, you're gonna get rid of extra hydrogens. So this is this paroxysmal, or sorry, I was saying that wrong, paradoxic aciduria. Meaning if you're in a state of metabolic acidosis, why do you keep peeing out acid? You want to keep the acid, but you can't because you're sacrificing that to try to bring back potassium. Okay, and then briefly, again, this is a term 4 issue, loop diuretics. The whole goal is to stop the sodium from being, well, both diuretics here, the whole goal is to stop the reabsorption of sodium. And by doing that, you're keeping the water in the urine to get rid of it. So you're diuresing the patient. Okay, again, those thiazides can lead to hypercalcemia just because they're located at the distal convoluted tubule where PTH is active. Now, if you have primarily, you compensate with the other mechanisms. So if you have a problem with respirations, you compensate with the kidneys. Again, that takes a little while. If you have a problem with the kidneys, you could compensate by ventilating, changing your ventilation. That's more of a quicker compensation mechanism. But you can actually, if you have some sort of metabolic acidosis, if the kidneys are okay, you can also compensate with the kidneys. So again, if you have metabolic acidosis, quickly, with a quick response, you can have respiratory, change your breathing patterns. But if the kidneys work okay, you can also try to compensate metabolically through the kidneys. Okay. And let's see. Okay, now let's say we have acidosis. Remember, we said that to get rid of the, to try to correct for the acidosis, we're going to get rid of acid in the urine. So we're going to increase phosphate and ammonium excretion to try to decrease the acid in the body to go back to equilibrium. Metabolic alkalosis means you have your blood's too alkaline. So we know bicarb is treated like, by increasing bicarb loss, you're bringing the body back to equilibrium. So that's our way of getting rid of these alkalotic agents, okay, by getting rid of bicarbonate. So acidosis, get rid of extra acid. Alkalosis, try to get rid of the extra base. These are the ways the kidneys are going to compensate. This is from first aid. It kind of puts everything there. Some of the stuff you don't really need to worry about just yet, but it's all there. Just memorize this. I mean, you can just break it down by looking at the values, but if you memorize what quadrants go with what, those are easy points, okay? But if you correlate it to low bicarb and high pH, that would obviously be respiratory alkalosis and whatnot. Another way of breaking it down, acidosis versus alkalosis here. But yeah, so you obviously look at your pH and what's going on to cause the pH. Remember, we treat carbon dioxide as an acid. Okay, and this is just from first aid. And what you do, remember these red arrows are your compensatory mechanisms. How are you compensating for it? So general sense, if you have a metabolic problem, you compensate with respiration. If you have a respiratory problem, you compensate with the metabolism. Can y'all hear me okay? It says my internet's unstable. I guess it's okay. Okay, cool. Yes, all right. So now we'll break down how this actually works. So respiratory acidosis. Acid means we're holding on to acid. Carbon dioxide is our acid. If we're holding on to it, that means we're breathing too shallow. We're not breathing enough. We're hypoventilating. That's why we have so much extra carbon dioxide or extra acid, okay? So again, if we were gonna compensate for this, we would have to do it metabolically. You can't, if you're hypoventilating, that's the problem. I mean, you're not gonna be able to correct it by just starting to hyperventilate, like something's actually causing the hypoventilation, like opioids or whatever, which is the example they like to use. So if you're having a problem with your breathing, you have to compensate with the kidneys, okay? So chronic respiratory acidosis means chronic hypoventilation. You're holding on to carbon dioxide. To compensate, you're going to try to hold on to your base, right? You're in acidosis, so you hold on to the base to try to fix it. Causes of hypoventilation, the main one they talk about is opioid use. Chronic or extensive opioid use can lead to hypoventilation. I guess technically, yeah, they could ask about phrenic nerve. Remember that supplies the diaphragm. Also, these COPDs and lung diseases, you're not getting proper gas exchange with the carbon dioxide. Again, you're holding on to carbon dioxide. That's an acidosis. Now, alkalosis means you are breathing too quickly. You're getting rid of the acid. If you get rid of the acid, you have alkalosis, so hyperventilation. Anxiety, they always talk about anxiety as the reason for that, or one of the reasons for that. So again, you would have to compensate with the kidneys. Chronic respiratory alkalosis. So how do we compensate? Well, if we have alkalosis, then we want to try to get rid of our base to bring us back to equilibrium. So if we could try to get rid of the base, we could try to get correct for this respiratory alkalosis. Now, hyperventilation, okay, anxiety is the one they mostly talk about. Fever too, hypoxia, again, you're hyperventilating, you're getting rid of too much carbon dioxide, you're in an alkalotic state. Now, metabolic acidosis means you're either holding on to acid or you're getting rid of too much base. So here we talk about getting rid of bicarb, which would lead to acidosis. So a lot of times this is due to diarrhea. Diarrhea is the one I talk about here. It'll cause decreased blood volume, but you also lose a lot of bicarb in your diarrhea. So how do you compensate for metabolic acidosis? By breathing differently. So if we're in an acid state metabolically, we want to get rid of our acid through the respiratory system. So how do we get rid of acid? We want to hyperventilate. Okay, that's our compensatory mechanism. And again, there is, nothing in medicine is black and white. So even though you have a metabolic problem and you're going to compensate with the respiratory system, you can sometimes use the kidney as another compensatory mechanism. So again, metabolic acidosis, you're going to hyperventilate. Okay, great. You're trying to correct it, but you can also try to pee out more of the acid. Okay, again, to bring us back to equilibrium. So just make sure you sit with these and talk yourself through these, because it's a lot of words and a lot of shifting values, and you just need to make sure you have it straight on the exam, because this is the most important thing for this exam. All right, diabetic ketoacidosis. Y'all will talk about this later. This happens in type 1 diabetics. But again, acidosis. This is a metabolic acidosis. So due to this insulin deficiency, they can't regulate their blood glucose. They end up making ketones, and that's acidosis, or acid. That ends up with acidosis. Okay, so keep that in mind as one of the causes for metabolic acidosis. Anion gaps are just these unmeasured anions, right? So cations always going to be sodium. The anions we primarily worry about are bicarbonate chloride. So if you have, or a HAGMA, or is what they call it, high anion gap metabolic acidosis, that's usually these unmeasured anions. I do believe you'll have to, there we go. You'll have to know this equation. So this is our anion gap. So if it's a non-anion gap metabolic acidosis, it'll be outside of the range of these things. So just make sure you know that equation, and that would be our standard anion gap. They'll probably give you that though. Okay. Now, metabolic acidosis, what could happen? Again, we talked about diabetic ketoacidosis, lactic acidosis if you're working out a lot and you have anaerobic metabolism, and chronic renal failure as well. Can cause a lot of problems, but decreased excretion of these sulfates or phosphates. Remember, we said phosphate was an acid. If you can't get rid of it, you can have acidosis. But also, not only holding on to acids, but getting rid of too much base can lead to it. So like I said, the one I'll probably ask you about is diarrhea. You're getting rid of the bicarb. Renal tubular acidosis. Again, it has acidosis in it, so it's metabolic acidosis. Acetazolamide is going to prevent the reabsorption of bicarb. So it's a medication they use for altitude sickness. So if you use that, you can eat too much, or it can lead to increased excretion of bicarb. Okay, switching, metabolic alkalosis. So in this sense, we're holding on to bicarb, or holding on to base. Same thing as saying we're getting rid of too much acid, right? So either way, but we're in a state of too much base. So how do we compensate? So if we have metabolic alkalosis, then we want to try to hold on to our acid. How do we hold on to acid? Where's the word? Oh, here in red. We hypoventilate, right? By hypoventilating, you're not breathing out the acid, so you're holding on to it. Okay, everything works concurrently. Now, again, that trick, even though you're in a state of metabolic alkalosis and you're compensating with your breathing, the kidneys can also try to get rid of this excess base, excess bicarb, okay, to try to bring it back to equilibrium. Causes of metabolic alkalosis, remember the acid in your stomach, so vomiting, right? Vomiting will cause loss of acid, so it can lead to alkalosis. Nasogastric suction, same concept. You're sucking out a bunch of acid. Antacids will neutralize the acids, so you can have alkalosis. And then, yeah, we talked about Cone syndrome, right? And then again, with this, we have that paradoxic aciduria. So we're getting rid of hydrogens, therefore alkalosis. Okay, diuretics, yeah, you probably don't need to really worry about that right now. Okay, mixed disorders. The key thing, the only thing is that in mixed disorders, your carbon dioxide values and your bicarb values will move in opposite directions. So if you're compensating, when you look at the values, they should always move in the same direction. So if they move in opposite directions, you have a mixed disorder. I don't think they asked us this, but I think Cassidy or Kishore said they had 1 or 2 questions on mixed disorders on their exam. So just make sure you know that this can happen, okay? All right, and then situations, the one that probably, if they do ask you, is aspirin poisoning. So aspirin is an acid, so it'll cause metabolic acidosis, but the aspirin also stimulates the respiratory center. So it'll cause respiratory alkalosis, meaning you're hyperventilating. So it's a mixed disorder. You get hyperventilation because it messes with the breathing center in the brain. So you get hyperventilation, but you also get too much acid in your system. So it's not going to cause a respiratory alkalosis and a metabolic acidosis. Okay, so a little tricky there. Okay, now this is how we're going to do these. This is what you need to focus on. So first thing is you look at the pH and you say, does the patient have acidosis or alkalosis? Then you're going to ask yourself, well, what's going on? Are they vomiting? Do they have diarrhea? What's the problem? What is the primary problem? Okay, metabolic or respiratory? Okay, and then you're going to ask, well, is it chronic or not? Meaning, are they able to compensate for it? If it's some sort of acute problem, they probably haven't compensated. But if it's a chronic problem, then you need to look for compensation. Once again, memorize these quadrants. That'll be a couple points on the exam. We're going to go through some examples in a second. And then if you're one of these people that likes these crazy graphs, then it's there for you too. All right, so normal ranges, they should give you these on the exam. Honestly, if you just memorize these, it'll make your life a little bit easier. Just know I use 40 for your arterial concentration of carbon dioxide, and 24 is good for bicarb, and 7.4 for pH. So it should vary significantly from these ranges, and you can go from there. All right, so cystic fibrosis, that causes lung problems, increased productive cough. Okay, so it could have a fever. Right, so we'll go with that. So first step, acidosis or alkalosis. Acidosis, right? Should be 7.4. It is 7.3, okay? Second step, okay, so acidosis. Second step, what caused the problem? Is it respiratory or is it bicarb? Now, my first thought is, I know cystic fibrosis has a lot to do with lung problems, right? Coughing up lungs, plus a fever too, that's never good for your breathing. So I would lean towards a respiratory problem. So let's check it out. PCO2 should be 40, it's 50, so it's elevated. What does this mean? You're blowing off more carbon dioxide. Okay, so if you're getting rid of acid, that would be respiratory alkalosis, right? Then we could check our bicarb, 24, so we're in a normal range. So it seems like this is an acute process. There's no compensation going on, but you are breathing too heavily, okay? So yes, respiratory problem. Sorry, wait, hold on. Should be, oh, I'm sorry, okay, wait, let me correct myself. So PCO2 should be 40, right? If it's 50, that means it's high. That means you're holding on to it. That means you're not breathing it out. Okay, so the patient's actually hypoventilating. Okay, sorry about that. So yeah, so if you have too much acid, you're holding on to it, so you're not breathing as much. Okay, so respiratory problem, respiratory acidosis, because you're holding on to this acid. And then we can say that since the bicarb is in the normal range, there's no compensation yet. Okay, so let me just say that one more time to make sure we got that straight. PCO2 should be 40, it's 50. So you're holding on to the acid. So this is a state of respiratory acidosis. We can confirm that with our pH, acidosis. So respiratory acidosis means you're holding on to the carbon dioxide, which is your acid, which means you're not breathing as much. That's how you're able to hold on to it. Okay, so hyperventilating, holding on to the carbon dioxide, therefore respiratory acidosis, and that makes sense, right? Now we check, is it acute or chronic? Well, our bicarb hasn't changed, so it seems like it's acute, no compensation. Okay. All right, vomiting right away. What's your thoughts? He's getting rid of acid. So right away, I would say, looks like metabolic alkalosis. Okay, so let's look into it. First step, 7.56. So alkalosis, right? Makes sense. He's throwing up hydrochloric acid. Now we're going to ask ourselves, even though we have a hunch, right? We want to check everything. So we want to ask ourselves, what is the problem that's causing the alkalosis? Does this cause alkalosis? No. Carbon dioxide is an acid. If you have increased this will not cause alkalosis. So that can't be the cause. Okay. Bicarb, if bicarb's supposed to be 24 and it's 32, does that cause alkalosis? Yes, right? Because you're holding on to the base. Makes sense, okay? So we can definitively say that of these two, this one is the one that would cause alkalosis. So we're in a state of metabolic alkalosis. Now we have to ask ourselves, well, is this acute or chronic? Has the patient compensated? Remember, the respiratory compensation is pretty quick, right? You know, second by second. So you could definitively say the reason that the patient is hypoventilating, right, holding on to acid, is to try to compensate for this. Yes, you would expect the patient to hypoventilate, increasing your carbon dioxide, increase acid. So this is an immediate response. So hope that makes sense. So first we could say easy enough, alkalosis. Which of these is causing alkalosis? No, that doesn't cause it, but this does. Metabolic alkalosis. Why is this off? Because you're trying to compensate for this alkalosis by hypoventilating and increasing the acid in your system. Okay. Again, you have if it's a metabolic problem, you can compensate with respiratory with your respirations pretty quickly, but you can also have renal compensation, but that takes time. Oh my goodness, I'm done. Lindsey.
Yes.
Oh, you up?
Yes, I'm listening to you.
Yeah, you are. I'm sure you are. I'm not even listening to me. Okay. All right. It's all you. After Lindsey does the questions, we'll go back and look at those. I'll try to explain it a different way with the volume contraction and stuff.
Yeah. I apologize. I turned my camera off because I'm laying down because I'm still having issues with the incision on my butt. So you guys don't want me lounging.
You could control my screen if you want to do that.
Okay, yeah, I'll do that. Request. Okay, so this question is really just asking where you find the ADH receptors. It's not even asking you the type of diabetes insipidus, which it will ask you. You will need to know the difference between central and nephrogenic diabetes insipidus. But here it's diagnosing the patient. So it's saying, it's kind of giving you the condition. So where are the receptors? And most of you guys are saying the same thing. It's the collecting duct. So good job there. I think most of you got it. Yeah, all of you are getting that right. What's the difference between the diabetes? So diabetes mellitus and diabetes insipidus. Diabetes insipidus is an issue with water retention, and it's due to ADH. So central diabetes insipidus is going to be at the level of the pituitary gland, the posterior pituitary. That's not really important for you right now. You're going to get into that in term 2. But what that does is you have an increase, you have an altered secretion of ADH. So you can get some syndrome of inappropriate ADH, SIADH, versus nephrogenic diabetes insipidus, where you the ADH is fine, but the receptors are messed up, and so the receptors in the collecting duct will not be able to respond to the ADH. And so that's diabetes insipidus versus mellitus, which is going to be associated with the oh my God, insulin. My goodness, my brain's not working. It's going to be associated with insulin and glucose. So that's the difference between mellitus and insipidus. Okay, next question. Okay, a lot of you guys are getting this correct. First off, what are we looking at here? A couple of you said it, but what structure are you looking at the tip of the yellow arrow? So you have a hollow lumen. It's open. What are we looking at? I'm gonna let a few more answer. Yeah, this is the Henle, loop of Henle. And so we can cross out 3 answer choices here because we are talking about the loop of Henle. So we can cross out C because juxtaglomerular cells are more associated with the glomerulus. It is hypoosmotic. Nope. Major site of reabsorption. So the loop of Henle, if you now we have to decide ascending segment. Okay, is that permeable to water or is it permeable to solids? And our answer is B. The ascending segment is selectively permeable to solids, and then the descending is going to be selectively permeable to water. That is important because the selective permeability right here is going to control that. Geez, I forgot what it's called. countercurrent system or whatever it's called. But that's kind of what controls it there. So understanding that concept is going to be important. I'm getting a lot of variation here. Or no, you guys are getting this right. But do make sure you do understand this because it's different for every step of the way. I remember drawing this out multiple times, but yeah, you guys are getting it, internal iliac. So that's just, do you know it or not? Most of you guys are getting this one too. Okay, do you guys want me to draw this out? It's better if you visualize it. You guys are getting it, but I can draw this out for you. Yep. Okay. Draw. Move this. Okay. So efferent, what are we talking about here? Basic definition. So we have afferent and efferent. And so we're constricting it here. What that means is pressure is going to build up on this side of the constriction, and then it's going to decrease on this side. So what that means is everything back, flow is going to, you're decreasing flow at this point. So you're decreasing flow through this area. And then the pressure is going to increase. So if we kind of stall everything in this area and we are increasing this pressure, we're going to increase the GFR, right? So I'm going to cross this out. We're increasing GFR because, you know, GFR is dependent on the pressures. And so your glomerulus is right down here. If we're increasing this pressure, it's going to increase the forces that are pushing it into the glomeruli. And so you're increasing the pressure. Now, renal plasma flow. This is the flow that's kind of continuing through here. So it's the overall flow going through this system. So from afferent to efferent, we're decreasing this flow because we're decreasing the blood flow overall into the efferent system. So we can cross out anything that says increase renal plasma flow. And then we have, oh, I don't know, it's not gonna let me do this. Oh, let me, sorry, I'm trying to show the answer now. Oh, no, come on. Okay, and we're increasing the filtration fraction because we are decreasing the renal plasma and we're increasing glomerular filtration rate. So that means you get an increased filtration fraction. Now, conversely, I'm gonna do annotate again. Conversely, if you constrict afferent, you're going to decrease flow, but you're also going to decrease GFR right here. And this also means that your filtration fraction is going to be unchanged. But that's really important right now. Understand the mechanics. When you get into later terms, you'll talk about what can affect afferent versus the afferent blood flow, because you can actually do this by medications, because if you have certain renal conditions, you want to make sure that you are monitoring the blood flow through the glomeruli, because if you have decreased renal function, you don't want to give a patient anything that's going to decrease renal plasma flow, because then that can screw everything up in your kidneys. And so you got to be really, really careful with certain medications. But that's a term for thing, but that's just, an example of how, information keeps building on top of each other. So for your purposes right now, know the overall concept, be able to know what happens if you constrict efferent versus afferent, and how it's going to affect those values. I don't know if this question was sent to me before I said it, but if you constrict afferent, the filtration fraction remains unchanged because you're decreasing both GFR and RPF. I said that, I don't know if it was before or after someone sent me that question, but yes. Okay, I'm getting a little bit of a spread here. That's okay. Most of you guys are getting it though. This is just one of those things. Do you know it or do you not know it? But most of you guys are getting it. It is the heparin sulfate because it is positive. So you're going to repel negatively charged things. So each component of the glomerular filtration barrier has its purpose in preventing or allowing certain things through. Heparin sulfate is the thing that is going to repel negatively charged particles. Yeah, a lot of you guys are getting it. There are kind of two things you can look at. I gave you a big, big, big one. What in the vignette, if you're not even looking at the ABG, is going to tell you exactly what this is. Yeah, the fact that they have an aspirin overdose. And so those buzzwords won't 100% of the time help you. There are definitely a few that are very big and very high yield and can narrow you down on what it is. Aspirin is one of them. But so we'll go through this. So you guys all got this respiratory alkalosis. Oh my goodness. So alkalosis, how do we know it's that? That's because we're looking at the pH. It's 7.55. Anything kind of above like 7.4, I think is the range, you are going to have an alkalosis. And then if you're looking at HCO3 and PCO2, again, somebody tell me in the chat, you can put it to everyone, you can say it out loud. What should you be looking for in these values? You can put it in the chat if you want. What's higher, what's lower, or you can just say what's normal. Do we remember? I'm not getting anything. Yeah, HCO3. Yeah, Yeah. Yeah, the PCO2 is decreased and then the HCO3 is normal. So that's how we can zero in on it being respiratory. So this is going to tell us the pH. We have an alkalosis now. Is it respiratory or is it metabolic? So we know that the metabolic is normal, or we know that bicarb is normal, but we know our CO2 is low. And so, CO2 is an acid. So if it's low, you're going to be alkalotic. And so this is telling us that it's respiratory. We are not compensated right now. This is just a respiratory alkalosis. How would we know if we were compensated? What would we see in the lab values if we were in compensated respiratory alkalosis? Yeah, the bicarb would be off. Our bicarb is normal, so we know that we have not yet begun to compensate. So if the bicarb is low, that makes sense. If we are alkalotic, we don't want bicarb in our system. So we're respiratory alkalosis, so our metabolic system is going to have to compensate. And so if our metabolic system starts compensating, the way it's going to compensate is it's going to lower the bicarb level, because that's going to try to bring it within normal limits. You can't really get it to perfect normal if you're in this situation, but you're trying to get it to as normal as possible so you don't cause deleterious effects. So you guys are absolutely right. Awesome. Okay. Moving on. Oh, sorry guys. Okay, well, I showed you guys the answer. So I'll let you guys read it and then we'll talk about it for a sec. NVD is nausea, vomiting, diarrhea. I can't talk today. Okay, so the answer is isosmotic volume contraction. We know it's this guy is dehydrated. And so nausea, vomiting, diarrhea, we're losing fluids, we're losing electrolytes, we're losing water, we're pretty much losing everything, which is why you're going to see an isoosmotic volume contraction. So not hyper, not hypo, it is going to be isoosmotic volume contraction because you're pretty much losing everything at this point. So contraction, of course, because you are you're losing fluid, you're not gaining it. So does that make sense why it's isoosmotic volume contraction? Okay, cool. But when it comes to contraction and expansion, do learn, okay. So the reason why it's isoosmotic, because if you are hypo or hyperosmotic, that means you are losing more of one thing versus another. So if you are, if you have increased salt intake, you're increasing your solutes. And so water is going to move in your body in response to varying tonic solutions. So since you are losing both water and you're losing solutes, you're having an isoosmotic volume contraction. You're just kind of losing everything out of your system. So there's
Sorry.
not.
Hey, Lindsey, when you're done with the questions, I'll go through those again. I think I have
Okay.
another way of explaining it. Yeah.
Okay, cool. Oh my goodness. Sorry. Yeah, I showed you this one again. Sorry, guys. So if you want to know, if you don't know what the abbreviations mean, he has uncontrolled hypertension. He comes to the ED for shortness of breath. Physical exam, he has edema in bilateral lower extremities, and chest x-ray shows pulmonary edema. But what you need to know is he is prescribed a medication at this point in term one. You don't actually, yeah, you do need to know that for furosemide, what type it is, to take the fluid off. So what is the mechanism of action? You guys are getting this because I showed you the answer. You were blocking the sodium chloride potassium co-transporter. Know the types of diuretics. I I'm pretty sure they give you a list of the different types of diuretics in your notes. I would be able to associate it with the types, and you need to know where they act. That was a thing in term one. So Brady showed you guys a really nice picture in first aid. That's what I used. It's color coded. So I'm a visual person. If you're a visual person like me, you can just learn where the colors are and where the diuretics are associated. It's not super high yield in term one. You'll have maybe 2 or 3 questions, but it's an easy 2 or 3 if you do understand them. But this is just a definition. All of you guys are getting this one too. Yeah, all of you guys are getting this one. Glucose. And then if you do have diabetes mellitus, if you overload your system, if the kidneys are overloaded with the glucose, one of the big things is you're going to see glucosuria, because you have overloaded the system so much that you don't even have time to have 100% reabsorption in the PCT, because there is just so much glucose. And so you do get some in the urine, and of course it's osmotic, and so it brings water with it, and so you have increased urination and increased thirst because you're losing the water. But that's a whole other issue. We don't need to go into term one, but it happens. Okay.
Whoops. Okay. Okay, quickly, let's go back to that stuff. I think I confused you guys, so we're gonna make it super easy. Hold on. Okay, here we go. Now, you want to ask yourself 2 things. Are we losing solutes, right? Are we losing sodium? Are we losing all the particles in solution? Are we losing water? Are we losing them equally? Are we losing more of one than the other? Osmolarity is going to be our y-axis. Water is going to be our x-axis. So in an instance of diarrhea, what are you losing? You're losing a ton of water, and as Lindsey was saying, you also lose electrolytes, okay? So in that sense, you're not really changing your osmolarity, okay? Because you are losing electrolytes, but you are getting overall volume contraction, okay? So by contracting the volume, you're telling yourself, you're saying here that you've lost volume, but you also lost the solutes, or the particles in solution, equally, okay? Now, if you say water deprivation, what's going to happen? Well, you're just losing water, right? So the concentration of particles in solution is being increased due to the loss of free water. So what would you expect? Well, you lost free water, so your x-axis is going to be contracted, but you also have an increased concentration of particles. And that's just because the amount of water got decreased, so the percentage of particles in that solution is more concentrated, okay? Adrenal insufficiency, in that sense, you're gonna lose a lot of free water, but you're also going to lose particles, right? Because the adrenal system regulates all the sodium, potassium, and everything else. So what you see here is you actually get a bit of volume or water loss, but overall, you're going to get a lot more loss in the particles, right? So your osmolarity goes down. So you're losing a lot of particles. The solution is getting more dilute. Okay, and that's because, and it's more complicated than that, but you're talking about aldosterone, you're talking about the regulation through the tubules and stuff like that. So if you have adrenal insufficiency, you can't regulate, you can't hold on to the glucose, you can't hold on to the amino acids, you can't hold on to the sodium, you're peeing it all out. So you get an overall decrease in solutes overall, okay? Now, if we look at, okay, so if we give isotonic sodium chloride, so 0.9% sodium chloride, okay, that means we're staying isotonic. We're not increasing or decreasing the amount of particles in solution at all. We're staying equal, but we're adding fluid, okay? So we're getting volume expansion, but we're not changing the level of the osmolarity because it's isotonic. All right. Now, what if we give a whole lot of sodium chloride? Well, that's a little tricky because water tends to go with sodium. So you see this shift. So you have increased or a shift in the water, but note that the osmolarity went up just because you're increasing sodium. So you would expect that because of the solutes in the sodium that you're just adding. Now, SI-ADH is an example where you're holding on to too much free water, syndrome of inappropriate antidiuretic hormone, right? So you're pulling in all this free water. So if you're pulling in all of the free water, you get volume expansion, but it's free water. So the solution is becoming more dilute, and that's why your osmolarity went down. So if you keep this in mind, you can determine each and then just know for each situation what's going to correlate with what. Okay.
And it's not that complicated on the exam.
It's really
honestly.
not. It's really
like,
not.
Understand contraction versus expansion and understand hypo, hyper, iso, but only understand it with respect to the examples. And yes, if you really want to dive down deep and understand it, feel free to. But if you're down to the wire and you're just trying to do it right now to get points on your exam, just learn the examples and then learn what's associated with it. And that's how you're going to get your points in term one, honestly.
All right. So
Brady, we had a request to go through that first aid pick of the diuretics.
Okay. Yeah, I don't think I really need yeah, we could look at it.
I mean, honestly, just know where it is and then mechanism of action.
Yeah, I just put that on there so y'all could kind of see what's going on, but like y'all really do like a whole module on that. And do y'all remember what slide it was? I don't even know. Y'all do a whole thing on the diuretics.
Yeah, it's really just memorization for you guys at this point.
Like loop diuretics act in the loop, thiazide diuretics act in the distal convoluted tubules. But I'd be very surprised if they gave y'all any of these on the exam.
Where's that first aid?
I have no idea. Anybody know?
Go before this.
I don't know.
Yeah, it's not any more complicated than what we're telling you guys, though. We promise. Like, go find it in first aid. The picture's in this review somewhere. It's color coded. It really just tells you where it acts, and then a couple of the mechanisms of action. But there are only 5 that they give you, though. There aren't even that many that they give you.
I think it's coming up. Hold on. Nope, maybe not. I don't know. Yeah. Sorry, guys. Oh, was that it? No.
Under blood pressure and volume, someone said. Oh, there it was.
Oh, there
This-
it is. Oh, God. No. Yeah, I really wouldn't worry about this, but we'll touch on it real quick. All right. Right. So angiotensin 2 is going to work on primarily the efferent arteriole and this area to constrict. That's not a medication. That's what we use with that RAS system. Parathyroid hormone is going to be over here, primarily in the distal convoluted tubule. Atrial natriuretic. So this wasn't the drugs though, but atrial natriuretic peptides.
The drugs.
I could walk through the drugs real quick. So acetazolamide is for mountain sickness or high altitude sickness. It works over here to so you don't reabsorb the bicarb. Then in the loop diuretics like furosemide, Lasix, if you're familiar with that, that's going to work here. It's going to work on the NCCK channels. So you actually get hypocalcemia with this, but y'all don't need to worry about that. Distal convoluted tubules, your thiazide diuretics work there. So like hydrochlorothiazide, HCTZ, you get increased calcium or hypercalcemia. That's the primary problem with it. Then over here in the late distal convoluted tubule and in the collecting ducts, you have aldosterone inhibitors like spironolactone. So they'll prevent aldosterone from reabsorbing sodium. You keep sodium in the urine, so you pee it out. So you pee out water, so you decrease blood volume, right? And then they also have ADH inhibitors, but that's more like when you're talking about syndrome of inappropriate ADH. But anyway, y'all really don't need to.
Yeah, it's 2 or 3 questions max, quite honestly, guys.
Yeah, for sure. And they won't make it complicated. No. Y'all deal with that in term 4. Anyway, it's been fun working with you guys. We'll be back next term with y'all. We'll do our best. Keisha will probably help us out with some of y'all's reviews. For those that will be coming down to the island, I'll look forward to it. See y'all in a couple weeks. Everybody wish Lindsey the best. She's going to get better. She'll be down here in a week or 2. And we'll let y'all buy us a beer or 2. All right. So good luck on y'all's exam. If y'all have any questions, just
congrats on being almost done with term 1. We know you guys can finish strong. We know it. Just do that last push to the end. I know it's hard sometimes, but we believe in you. We know you can do it. And congrats on finishing your first semester of med school.
Yeah.
Brady, sorry to interrupt. Is it okay if I quickly ask you a question about the Darrow diagram? So
Sure.
When there's like an expansion to the left for intracellular fluid, that means that the volume is going up, right? Even though it's like going left on that axis.
Right. Yes, it does. Yeah, it expands. They do. It's weird. Yeah, yeah. But anything outside of the zones, you would just take a measurement from the box to the outsides. But yes, to the left would also be an increase. Yeah.
Okay, thank you.
Yeah,
And
like
just one last thing is, like, whenever we see nausea, vomiting, diarrhea, does that always mean isoosmotic change?
Yes.
Classically, yeah.
Yeah, classically.
Okay, thank you so much. Thank
for
you
your purposes in term 1. Yes.
Yeah.
Okay. All right. I'll keep that in mind. Thank you.
Yeah.
All right, guys. Big picture.
Good luck, guys.
Y'all are doing this for a good reason, right? So good luck with everything. We will be in touch. Bye, guys.